Professor Baha Karana, one of the best hip and pelvic surgeons in Egypt from Al Azhar University, and Professor Saad Sholah. He's a very, very clever acetabular man, acetabular surgeon from Banha University.
You're welcome.
Thank you, doctor.
I'm just making the announcement for the start of the day. Sir, we are ready to start. Can I make the announcement, please? Bismillahirrahmanirrahim. It's a great honor for me to announce for the beginning of this very special day, the pelvic specialty day in the course specialty days. We had 3 specialty days before, and this is the 4th. What makes this day special is we have the best of the best speakers from India, from Canada, from Egypt. We have 2 of the best pelvic surgeons in India and all over the world, Professor Vivek Trekha and Professor Abhail Hans from All India Institute. We have from Canada, Professor Walid Kashta, the head of the orthopedic department, McMaster University. And we have 4 eminent speakers from Egypt, our dear professor, Professor Baha Karana from Al Azhar University, Professor Mahmoud Badran from Asyut University, Professor Ahmed Khamis and Professor Saad Sholah from Banha University. We will start with our great professor, Professor Vivek Trekha. Professor Trekha will speak about the anterior pelvic injuries. Thank you so much for joining us, sir. Thank you.
Thank you. Good afternoon and good evening to everyone. And thanks for the invitation. I shall be speaking on the anterior pelvic injuries. I hope you are able to see my slides.
Yes, sir.
Okay, so I shall be discussing the anterior pelvic injuries and the reduction and fixation about it. No disclosures from my side. The learning objectives of this talk are going to understand the indications of fixation of the anterior pelvic ring in pelvic fractures, to see which are the approaches and how we can manage these fractures, and also to demonstrate the different fixation methods which are available to us. First of all, let's understand what do we mean and what are the fixation principles in pelvic injuries. First of all, what we need to understand where the anterior pelvic ring injuries fixation helps us. In an unstable pelvis, which is completely disrupted, the anterior stabilization contributes significantly to the strength. But remember that it's the posterior pelvic ring injury which defines the ultimate stability. So what does anterior fixation do? It enhances and augments the posterior pelvic injuries fixation. And if there is some deficiency in the posterior pelvic ring injury fixations, the anterior fixations are going to contribute to the strength and maintain that reduction till the union happens. We are going to discuss the 2 main things, which are the pubic rami fractures and the pubic diastasis, which is the symphysial disruption or the joint opening up. Where does the symphysis disrupt? So if we look at it in a pelvic injury, wherever the symphysis opens up anteriorly are mostly common in the rotational type of injuries, like in APC 1, 2, and 3, where the anterior-posterior compression happens and the ring opens up one after the other from anterior to posterior. This is based on the ligamentous disruptions. In many of the vertical shear injuries also, you will have the symphysial disruptions. And the lateral compression injuries are the ones in which the pubic rami usually gets fractured. Can we leave any of the anterior symphysial injuries of the grade 1, 2, or 3 of APC non-operatively? When can we do that? When there is a minimal opening of the pubic symphysis, there is no associated sacroiliac injury or the posterior injury, and the displacement is less than 2.5 centimeter with stabilization, with mobilization, and with stress. When we assess that, it has to be less than that. So what are the indications for fixation of symphysis? All the unstable anterior pelvic injuries will be the indications. If we have a less opening or an opening which is less than 2.5 centimeter, then we do not leave it as such. We need to assess for the stability or instability and then decide whether it needs fixation or not. Remember, in the present world, where most of the patients of pelvic injuries have a binder put onto them, always and always check for the stability part besides removing and after removing the binder. Because pelvic binders can mask the amount of displacements and the stability which you will get. And therefore, you should assess it without the binder before deciding what is the management. This paper also suggests that, and this is a patient from our own hospital, where you will find that the CT scan shows a very minimal disruption of the interior pelvis. However, as soon as you open it up, the binder was opened and you find that the symphysis opens up dramatically. So you always check for stability without the binders. Don't just look at one X-ray and decide the management. Can we also do something else? How do we assess the instability? We can assess that by this paper by Claude Saji, which was there, which suggests that if you do some examination or anesthesia, where you flex the hip, abduct, and externally rotate the pelvis, both the lower limbs, and then see how much is the displacement, you can find out the occult instabilities and then decide whether these patients require any fracture management or not. And what they found was that in nearly APC1s, which have got minimal displacements, there was instability in nearly half of them. And nearly in LC1 also, nearly 40% of the patients had instability. How do you do that? You can take the patient under C-arm, flex the hips, as I said, make a figure of 4 sort of an external rotation pelvis, which will open up the symphysis for you. You can pull and push stress tests to look for the vertical rotational and displacements of the pelvis, and then decide whether you really need to fix these pelvis or not. Just don't leave them as such. Once you have decided that you need to operate upon a pelvis which anteriorly, mostly what we do is the patient is taken under general anesthesia in supine position with C-arm, which is opposite to the surgeon. Foley's has to be put in and you shape the parts. Fan and steel incision is the standard incision which is used. Remember, do not try to cut and transect the rectus tendons. Partly part of one rectus will be cut and torn because of the disruption. So don't remove it as such in transverse fashion. Try to erase it longitudinally from subperiosteally from the interior part of the ribs. And then you put the plate superiorly so that you can have long screws inside. So a patient like this, which has got a diastasis opening up of more than 2.5 centimeter with an SI joint opening, you go in, give a fan and steel incision, which is 1 centimeter above the symphysis, open up the subcutaneous tissues, cut the linea alba, which is already torn in such conditions. Once you open them up, you will have the basis or the space of Retzius with the bladder in front of you. And once you open and retract the bladder, you can get the symphysis to be reduced with a reduction clamp and then fix it with a plate. How do you reduce it? This is how you can put in a Weber's clamp into the foramina obturator and get the fixation which you desire. The reduction of symphysis is usually done by internal rotation of the lower limbs. You can use an external fixator if the patient is bulky, and you can also use the Weber's clamp after you open on the pectineal eminences or into the obturator foramen to reduce these things simultaneously. You can note that even the ankle and the lower limbs are internally rotated in one of these patients, which helps us to get the closure of the diastasis. If you still are not able to get the closure, you can use some screws and clamp reductions as was told by Mata and Tornetta, which is shown in this one of our cases, where we did the reduction by putting in 2 screws in the 2 hemipelvises anteriorly in the anterior side, held them with Jungblut clamp and reduced them, and then superiorly you can put in the plate which you desire. However, remember that this requires some more erasure and removing the rectus muscles when you do this thing in the anterior part. So these are some of the cases which I would like to show. This is a case where the diastasis is opened, the symphysis is opened. You can see the left side SI joint which is open, can be seen in the CT scans in a much better way, both the 2Ds and the 3Ds. So this is how, whatever I told you, this is how you reduce it with the Weber's clamp at the pectineal eminences, internally rotate the lower limbs. If required, put in an external fixator and Jungblut clamp if you want, and then you can fix it with plates with minimum of nowadays 3 screws on either side are normally put so that you get an adequate stability of the anterior pelvis. And then subsequently the posterior side was also fixed. So this is how you can get that reduction from there. This is 6 months follow-up with no movement, and you can see that the symphysis is still in the same place. Sometimes, instead of opening up of the symphysis in an anterior pelvis, you can have a pelvis which has got locked pelvis. Now, this pelvis is also broken and symphysis is disrupted, but instead of opening up, the compression has happened. It's a lateral compression sort of an injury where the locking of pelvis happens. Here, the ligaments are not broken, but they are shortened. And hence, you need to do the opposite of what you are doing in an APC injury. That is, you open and distract both the hemipelvises and try to do as early as possible, because otherwise the ligaments contract. You can have damage to the soft tissues, especially the bladder or the urethra in such conditions. So be wary of that and always take precautions and always see whether the bladder and the other structures, which are hollow viscous organs, visceral organs, are fine in such cases. So here you need to reduce the hemipelvis both from the posterior and anterior simultaneously. You might need to put in a shank spin at the anterior inferior spines and distract with the figure of 4 position of lower limbs, and then fix this pelvis with the plate as you desire. Now, this was done around 15 years back, and the patient is still fine with good outcomes. Sometimes you have bladder injuries which are associated with such conditions, and anterior fixation needs to be done. You can see in this that the bladder and there is a fluid which is extravasating, and with the posterior injury and the anterior injuries, which was extraperitoneal bladder rupture. So when the urologist or your general surgeons is opening up making sure that they are reducing and suturing back the bladder rupture, you can do the fixation at the same time of the anterior pelvis with them, so that you do not have to go later on and try to do the fixation at the same time as the surgeons fix up and repair the bladder for you. Is there any role of locked plates in the pubic symphysis? There is no advantage, which was shown in this paper in 2012, and subsequently also there has been a paper in 2020 which suggests that locked plates are not better than the standard plating in pubic symphysis if you are able to put in 3 screws on the either side. However, you might find that over a period of time, there is some gaping or a widening of the anterior symphysis, which happens post-operatively. And in this paper and one of the other papers by Chip Rout and Corey Collinge, they had nearly 88% of symphysial widening But this is incidental and it does not lead to any revision surgeries when you follow up the patients and find that the symphysis opens up, but they usually do not open up more than 1 centimeter. So you need and you should be aware of this and should not be worried if it is less than 1 centimeter of opening up in the postoperative period. Can we use the dual plates? Yes. Anteriorly, the dual plates can be used, but most of them are usually used in elderly patients with the fragility fractures, as was shown in this paper by Professor Romans and Alexander Hoffman, who suggested that you can use dual plates in cases of fragility fractures. Now let's come to the another part of the anterior pelvis, which is the rami fractures. In rami, you can treat them non-operatively, but again, remember it's the instability that we are trying to correct and not the fractures in true sense in the anterior part. You do the operative when it is unstable, there is internal rotation, damaging the soft tissues, and there is a Libland discrepancies. Always and always check for the instability both anterior and posteriorly before decision making of the pubic ramus fixation. There is a classification by Nakatani which says and suggests that if the fractures are or the fracture pattern is close to the pubic bone, that is zone 1, near the obturator foramen in the part is a zone 2, and laterally towards the acetabulum is zone 3, the root of pubic rami. And based on this, we decide how and when to fix the pubic ramus. As I said, X-ray is static, always assess the views. In lateral compression also, you need to do the same as was shown by Claude Saji in his paper. And what they suggested that if you compress the pelvis and the overlap happens more than a centimeter, then that is unstable and it requires a fixation. By Joshua Perry and Cyril Moffrey, there is another paper which suggests a lateral stress radiograph. In the casualty or in the emergency department, you take the patient in a lateral view and get a AP X-ray of that. With the pressure and the stresses, you will find the overlap of the pubic rami. And if it is more than 1 centimeters, you need them to be fixed. Otherwise, they can be left without fixation, conservatively treated. Once you have decided to treat them operatively, you can either fix them with plates, screws, or fixators. Now, this is a case which looks very normal, not much of the displacements. But if you look at the CT scans, this spike of the pubic rami was impinging into the bladder wall. And that would have led to stasis and development of stones. Besides, the SI joint was also opened up. So it required some fixation. And we are asked by our surgeon friends that we need to improve this bladder condition. And that's why the pubic rami was fixed with a plate here. If the fracture is very close to the symphysis, it's mostly better and prudent to put in a plate which is holding that fracture for you, because the screw may not be able to hold the pubic rami in a good way. Sometimes, as I said again, a zone 1 sacral fracture with a very close to pubic rami fracture, which is next to the symphysis, as you can see in the 3D. Here, the bladder was ruptured, and you can see that in the CT, where you can see that all the things and the extravasation of urine is happening all round up. Bladder was repaired. And as I said, at the same time, you can see the displacement on the left side of the image, the pubic rami, which was going inside, which was removed, and the skeletal fixation was done at the same time of the pubic rami with the bladder repair. You can also put in the pubic rami screws, both antegrade and retrograde, which helps it to make it very easy without disruption of the muscles and blood loss. Normally, as I said, if it is in zone 1 or 2, put in the screw from the pubic rami towards the acetabulum, which is a retrograde fashion. And if it is more close to the acetabulum, you put the screw which is coming from the acetabulum towards the medial side. The views which you take are obturator and pelvic inlet views, which gives you that the screw and the guide wire position is inside the joint, and you can get the screw fixation both looking at obturator oblique as well as the inlet pelvic view. Mind you, if you're doing it percutaneously, your entry point has to be not at the site of hemipelvis, which is broken, but slightly away on the other side, so that you get the good gradient and the angulation to put in the screws in the desired way you want. Now, this is again a case of a pubic rami where you can see that the SI joint disruption is there along with some morale level, which you can see. So this required fixation, which was done posteriorly. Posterior was the most important thing. However, to augment this fixation, because it was a highly unstable fracture, a pubic rami screw, which was antegrade, was also put for this case. And you can see 6 months later that the figs has completely united and the patient is okay. Now look at this case. Here the posterior part has a sacral fracture, but the anterior bilateral pubic rami have got broken. Highly unstable, patient was severely hemodynamically problematic. We revived her, resuscitated her, and once after getting the CT scans, here also both posterior and anterior fixation was required, and hence with a minimal opening anteriorly and a minimal opening posteriorly without opening up the entire fracture, screws were put. She was a 19-year-old lady or a girl, and the pubic rami were not that big, so a smaller screw was put inside to hold the pubic rami because they have a very good periosteum and they will unite very fast. So you require the stability for the initial 6 to 3 months. And this is her 18 months follow-up, and you can see that everything has completely united. The antegrade screws going from the acetabular side towards the pubic rami are much more common and easier to do, which are usually done for the Nakatani zone 3 and root of pubic rami fractures. So like fractures like these, which are close to the acetabulum, you can put in a screw going on from the lateral side towards the medial side, looking at the same views of obturator and inlet views. This is another case which I showed you regarding the CT scan of the pelvis. And what we found out was that wide opening here, it was there with both the symphysial disruption and the root of pubic rami bilaterally, along with an SI joint opening on one side. So in a minimal invasive way, the posterior screws were fixed and the pubic rami as well as the symphysis was reduced and fixed with minimal amount of dissection and just a fixation like this. And this is her 2 months follow-up. It was done in January this year, and she is okay till now. Another case which you can see sometimes when you have a bladder rupture and an open bladder with abdominal compartments, you cannot do these fixations. So sometimes in constrained environment, you also need to put in a supraacetabular fixators, which may also act anteriorly and give you adequate stability, which will help and augment the posterior fixations. Finally, I would go into a new technique, which is usually used, which is an infix, proposed and propounded by Rahul Vaidya. And what it is that it is used as a supraacetabular fixator instead of an external fixator. It's an internal fixator used in obese patients or in cases where the bladder injuries or both the rami fractures and symphysis, which you do not want to fix, are there, which helps us to keep a fixator inside the body, like in this highly obese patient, which required a fracture fixation of the pubic rami. An infix was put, and subsequently, you can keep this patient who can walk, who can move around without any issues, without sit, without any cosmetic issues for the initial 6 months. And later on, subsequently, you can remove these screws after 6 months to 1 year. Another of these cases, which was just recently fixed by us, again, a lady with a huge belly, pot belly, as well as the abdomen, which was fixed, which we didn't want because of her concomitant abdominal injuries, which were there, the urine problems, which were there. So we just fixed it with an infix, making sure that the pubic rami are in contact and they will unite fast. And these screws can be removed after 6 weeks, 6 months to 1 year. So I have shown you an entire gamut of fixation of the anterior pelvis, which can be done. Symphysial fixations and pubic rami fixations. Remember, you do the definitive fixation of these fractures based on the diastasis. You do that when it is having an opening up or the posterior instability is there. And when your displaced pubic rami are there, which are associated with posterior injuries or instabilities, then you are going to fix these up. Again, I would say that remember this, though it may look more glamorous to fix the interior part because you have a lot of fixation tools. Anterior fixation just supplements the posterior pelvic stability. It protects the posterior fixation from failure. So you cannot just fix the anterior side and leave the more important posterior side unstable. You need to do fixation very well of the posterior side as well. Pubic diastasis, whenever it is there, you look into the structures, you look at the occult instability, try to check out for the patients with their instability test, which was defined by Saji. Take the x-rays which are out of the binder and then decide whether this symphysial diastasis requires any fixation or not, usually done with a plate through a fan steel incision. There are specific indications. Not all pubic rami fractures require fixation. However, the fractures which contribute to the instability of the pelvis will definitely require those fixations, where you have the options of using a plate, which I have shown you, the screws which may be both antegrade and retrograde, and also sometimes an external fixators in constrained environment, and in highly obese patients, you can use a method like Infix for fixation of these pubic rami fractures. I thank you for your patient hearing and again reiterate that the next talk is going to be more important because it's the posterior pelvis which is more important than the anterior part. Thank you for your patient hearing.
Thank you so much, sir. Thank you so much, Professor Vivek, for this very interesting presentation. We have 10 minutes to receive questions to Professor Vivek. And the first question comes from me, sir, please.
Yes.
For fixing the anterior pelvic ring disruption, do you use the X-Fix as always a temporary way of fixation, or sometimes you use it as a definitive way of fixation?
Okay, now previously we were using the external fixators as a definitive fixation tool many a times. But nowadays, with the advent of modalities which have improved in minimally invasive fixations, we are using the internal fixations many a times. However, situations where the abdomen is opened up, you will have an abdominal compartment syndrome, or you have a laparostomy wounds, or in conditions which are highly obese patients, there we put in the external fixator, which are more for the pubic rami fractures, which unite faster than the diastasis. Diastasis, if you are using a symphysial diastasis, you are using a fixator, you need to ensure that you need to keep that fixator for at least 3 months, not for 6 weeks or so, because as soon as you open up the fixator after 6 weeks, as we normally do, for many of them, the symphysis will again go back and open up, recoil to its position. Hence, ligaments require at least 3 months of stability for their fixation, and the bony part requires around 6 weeks. So hence, that's why many of these things have the indication of using an external fixator has gone down, but it is still a very good way of using it as a definitive treatment for pubic rami fractures, especially in constrained environments. Many a times you will not have the fixation abilities of the fixation by many of the surgeons, as well as because of the economic constraints as well. I think pubic rami external fixator is a very good tool of fixation.
Yes, sir. We have many questions for you, sir, from attendees. Professor Bahar, please, sir.
Yes, can you tell us some tips and tricks about how to reduce displacement anteroposterior, especially if you have multiple fracture, 2 pubic rami, symphysis pubis?
One of the cases which I showed you in the last one, which had a pubic rami as a bilateral pubic rami and diastasis, that was a case where we had the issues, and this usually happens because the anterior pelvis is now highly unstable. So if you try to fix the symphysis first, it can happen that the inlet view of your pelvis, which is round in shape, can get contracted because the pubic rami are coming close and the inlet view or the inlet part of your pelvis gets shortened. So many a times after fixing, depending upon the stability part, we temporarily fix the anterior fixation, get our posterior reduction of the pelvis first, get the sacral pubic rami screws as I showed you in that case, or simultaneously open up the symphysis and the pubic rami in the intrapelvic approach and then put in a plate. I normally tend not to fix them with a smiley plate or a long plate or a large plate. I do fixation of the pubic rami as I showed in a percutaneous fashion, because I have my opening up of the symphysis in a small way. I can reduce my pubic rami properly, and then subsequently I do the symphysial reduction. If you have vertical or anterior posterior displacement of the hemipelvis, then I would suggest that it requires a dual opening up both posteriorly and anteriorly, and then trying to temporarily fix the anterior part and then reduce the posterior and subsequently fix the anterior. That's how we'll do. I think we will discuss it more with Professor Abhay's talk also of how and when we go in for both the fixations and reductions.
Thank you.
So, we have many questions for you, sir, from our attendees. Our first question from Dr. Faisal Al-Musrati. Can we use crossed cannulated screws for pubic symphysis diastasis?
Cross screws?
Crossed cannulated screws.
Okay, so you are trying to fix in a X fashion like this, as that's what you are saying?
I think so.
So remember that pubic rami and the symphysis has some mild movements. It's a short fibrous joint, if you can say that, but it definitely has micro motions to that. So if you put in the screws from the symphysial joint and then going in from one part of the hemipelvis to the other, and the patient is mobilized, you will find that the screws will loosen out fast. Even in patients with 2 screws on either side of the hemipelvis, you will find that the micromotion causes some opening up of the anterior symphysis, as was the paper which showed that nearly 90% of them have some widening. So cross screws are usually put in cases which are in non-unions or in a resurgery or a salvage surgery where you need to get a good fixation, where the bone has got weakened or loose bone is there, and then you try to stabilize it with putting in a bone gap graft and then putting in those cross screws. There is a newer technique which has come, which is now a W plate sort of a thing, which is having 2 plates with those cross fixations. But I think they are required for a specific condition where the bones are weak or it is a highly unstable entire pelvis, B3 or the rotationally or vertically unstable, severely unstable fractures bilaterally, or a fragility fracture, which will require such fixations. Normally 3 screws on either side, holding the joint in a proper way will suffice.
Yes, sir. Another question, sir, from Dr. Yaqub. Any tips or tricks to mini open to reduce pubic rami fracture when fixed by percutaneous screw?
Yeah, so it depends where exactly that fracture is. If it is close to your ramus, like in type 2, zone 2 Nakatani in the mid part of your obturator foramen, when you put in just like your nailing part, that you take the small short fragment, put in your nail through it, and then try to reduce your fragment. Same thing can be done slightly when you put in your cannulated drill or the drill from your symphysial area, and then you can do a minor reduction in the anteroposterior direction of the pubic rami. The problem is if it is overlapped, then it becomes a difficult thing where you need to hold that short fragment with a towel clip or something, and then bring and distract the fragments to bring them in alignment. I normally would open up slightly on the paramedian area and then hold the pubic rami with a towel clip and try to manipulate it slightly so that my reduction is good enough that a screw can get inside the medullary cavity of the pubic rami. If it is not, or it is highly overlapped, and with my distraction maneuvers also I'm not able to do, then I'll do a formal fan and steel to reduce those fractures, but put in the screw in a percutaneous fashion from whichever side I require.
Yes, sir. The next questions from Dr. Ibrahim Deep. What's the management of postpartum disruption of symphysis pubes?
Both parts of symphysis?
Postpartum disruption.
Postpartum. Okay, postpartum. So in a postpartum case, we many a times, if it is a contracted or a obstructed labor, you will find relaxin hormone. Because of that, the symphysis opens up, and it normally will subside within 6 months, 3 months to 6 months. We have published this around 20 years back in 2003 or so, when we saw and we had these cases, 3 or 4, where we just give them, you need to give them a binder. Make sure in the postpartum, if it is disruption is less than 2 to 2.5 centimeter, which most likely it is, it does not open up more than that. So you give them just a binder to reassure them and to also reduce the pain. And within 6 weeks to 2 months, you will find that it comes back to its position. However, if your disruption is more and you feel and the patient is not getting improved in the next 2 to 3 weeks, you can again go in and do the examiner anesthesia, do a figure of 4 position of both the things, and see how much displacement and opening of the symphysis is there. If it is more than 2 to 3 centimeters, because in ladies it is considered that 1.8 is good enough for the disruption, I would suggest that then you might have to fix. I remember one of my residents fixing it in his private practice once, where he had a case of 4 centimeter disruption. But normally, in my experience, they are less than 2 centimeters and they can be treated conservatively.
Yes, sir. Another question, sir, from Dr. Faisal. What are the indications for implant removal?
Implant removal, yes, that's a good question. Like in infix, if you are putting in an infix, it is an unstable, like we remove the external fixators. So you remove the internal fixators also, normally after 6 months, because if you do not, there is some micro motions happening and the loosening of the screws will happen. If you are putting in a symphysial plate, normally we do not remove it, except for me personally, I remove them in ladies and females of reproductive age groups, just to ensure that the gynecologist and the obstetrics do not cause any problems and say that it's obstructing their issues and pregnancy. So for in reproductive age groups, I remove them as a precautionary measure. However, for gents and for other people, males, it is not usually required, except the infix.
Yes. Sir, if your time allows us, we have about 5 to 6 more questions.
Yeah,
Sure. Okay, thank you, sir. Another question from Dr. Hassan, a danger of tilt fracture of pubic ramus.
Okay. The tilt fracture, because I was thinking of covering it up as well. The tilt fracture is one which can go both anteriorly and posteriorly. So once the tilt fracture, which is a breakage of the pubic rami along with the symphysial disruption of a unilateral hemipelvis, it is a significant injury. When it goes posteriorly, rather, that means that the displacement and the pubic symphysial region goes inside the pelvis, then you can have the disruptions again like a locked pelvis of the soft visceral organs like the bladder, the urinary, the urethra, and sometimes the prostate also in these conditions. So that is a difficult and a complex situation where you need to reduce it, remove it from the place. In females, when you have the anterior tilt of the pelvis or a inferior tilt of the pelvis, which of the pubic rami, what it does is the disruption of muscles is very much, and sometimes it can cause problems and prominence in their vagina. And then I had a patient who had problems in, what is that called? Dyspareunia was there, and she was having problems with that. So sometimes this can get prominent in the pubic rami in the vagina, which then requires some removal at that time. So preferably pubic rami, when they are having a tilt fracture, the soft tissue disruption is very much. So it's advisable that you fix them straight away.
Yes, sir. And the next question, sir, from Dr. Hamza, what's the sequence of fixation in sacroiliac fracture and zone 3 bilateral pubic rami and symphysial fracture?
Yeah, so that depends upon the type of displacement. I would normally try to go and fix a thing which is causing, which can help me and which I can see completely, like the anterior part. Because there I can open up in a fan and steel way, I can reduce the symphysis, which I have to open up. And at the same time, I can reduce the pubic rami, visualizing them and reducing them to the best of anatomical position. So normally I would go anteriorly and try to reduce them while trying to reduce the posterior part also with the joysticks in the inferior iliac spines, and like a forearm fracture, where both the ulna and the radius needs to be reduced properly before fixing them definitively. Same thing I would say we do for a pelvic ring also, that you try to reduce the interior rings first, but see if it is not helping the posterior part, you also reduce and get the both the reductions and then get the fixation definitively. I normally tend, until unless the pubic rami are comminuted, I tend to go for anterior fixation and reduction first, which might help me in getting an acceptable reduction and a good reduction on the posterior part of the sacrum, so that I can put in percutaneous screws without opening up the lateral windows at that time. So minimal dissection will help me, because anyways I have to open the interior part for symphysial disruption. So I'll definitely open that up and we'll see whether it aids in the posterior reduction. That's how I do. But fixation, remember, reduction and fixation are two different things, and you need to titrate them accordingly as you get the reduction.
Yes, sir. The next question from Dr. Ahmed Farag: what's more stable, anterior or superior symphysial plate, or both?
As I said, it's the superior plate which has got the maximum width of the symphysis of the pubic rami. So you can get screws which are 60, 70, and 80 if you go more laterally from the center part. Whereas the anterior plate will have screw lengths of maximum 20, 25, 20, 25, maximum 26. So theoretically and logically, the superior plate is much more stable than an isolated anterior plate. However, as I said, there is a paper which suggests that dual plating can be helpful, which is much more stable, especially if you have osteoporosis, there are fragility fractures, and a poor bone stock situations where your fixation may not be adequate. And also, if your posterior fixation is suboptimal, then maybe you can put in two plates on the anterior side, which will be more stable.
Yes, sir. Thank you. The last question, sir, from Dr. Bahauddin Ibrahim: can we apply symphysial plate with bladder injury or urethral injury, or better to do fix it by X-Fix?
Okay, so that's a very good question and relevant, because many a times it happens that we do not have coordination with the surgeons and the orthopedic surgeons, and they fix the symphysis or the bladder rupture reduction and repair has been done, and then 3-4 days later we are called to fix the things. If you can, the best time to fix the symphysis or the pubic rami is at the time when you open it up for the first time. Even if you are doing a bladder rupture, which is an extraperitoneal bladder rupture repair is being done, that's the best time to fix your superior pelvis or the plate anterior pelvis. If let's say that you cannot do that, if you go in later on and do the resurgery for that, for a fixation of skeletal stabilization, the chances of infection rises 3 to 4 times. Hence, I have shown you cases where it was possible for us to do the fixation simultaneously. At that time only, in an acute situation within 6 hours of the injury, and there we have done it simultaneously. However, if it is delayed, it is more than 24 to 48 hours, when it is said that the urine also gets infected, which is inside, then preferably, because of your local conditions and the environments in which we are working, we should be aware of our constraints and then do an external fixator or an internal infix for those cases, which will also suffice.
Yes. Thank you so much, Professor Vivek, my dear friend, for being with us in this very special day, the Pelvic Specialty Day, and for sharing your very long experience with us. Thank you so much, sir.
Thank you, sir. My pleasure.
Now we will move to the next speaker, one of the eminent pelvic and acetabular surgeons in India, Professor Abhay Alhans from All India Institute, AIIMS. Professor Abhay will speak about sacral fractures and spinopelvic dissociation. Thank you so much for being with us, sir. Thank you.
At the outset, many congratulations to the Egyptian Orthopedic Association, and especially Professor Al-Shahab for celebrating and recognizing that specialties are important. And many congratulations to you, sir, for the Specialty Day. So at the outset, the tone of my talk has already been set by Vivek's talk, which talks about the anterior pelvic ring. So let us define the actual indication and need to address the posterior pelvic ring by a case. So this was a 52-year-old male who sustained injury in a pedestrian accident and sustained a combined pelvis and acetabular injury. So these were his X-rays and his CT scans, both the 3Ds and the 2Ds. And what stands out, and I will summarize the injury for all of you, is that this gentleman had a bilateral posterior pelvic ring injury, had a left side type 3 crescent fracture. On the right side, he had a zone 2 or a 3 sacral fracture. If we quantify it further, it has an Isler type 1, which means that proximally the zone 2 or 3 fracture, it extended lateral to the facet joint. And then they had a double segmental anterior column injury with a tilt fracture on the left side. So obviously a very significant injury which required surgical stabilization for the instability that was present. And we dealt with the left crescent fracture first. Then we shifted through the ilioinguinal approach to the left side acetabulum fracture, reduced and stabilized the tilt fracture with screws and bone grafted it, and also stabilized the pubic symphysis on the anterior side. And then we went on the contralateral side and fixed the contralateral SI joint injury with from the posterior aspect with a tension band plate. And this was what the patient looked like. And this is now almost 3 years post, and this patient is doing well. Which brings us to the most important question today. Sacral fractures, what are they? So these are injuries where diagnosis is difficult and treatment is controversial. For most part, the patients are polytraumatized. So the diagnostics and therapeutics of other organ systems predominate the assessment of the patient's injury. The typical signs, clinical signs, are usually missing, and X-rays can be a little difficult to interpret unless somebody is a seasoned pelvic surgeon. Neural deficits are present, and the most important thing is that they may not be very obvious on primary surveys and initial and even subsequent clinical examination, because the patient may be in a state of altered sensorium or may actually not be able to identify and define if there is a problem in the region. Injuries like pelvic injuries and the posterior pelvic rings very often can be overlooked. Yes, that happens, misdiagnosed and neglected. So the important things are that these are injuries which have a very high incidence of neurologic damage. The most important thing, as Vivek also pointed out, is that the posterior pelvic ring stability is essential to weight transmission from the axial to the appendicular skeleton. And there are several methods of treatment present, but there are no specific protocols on how you need to treat a particular injury. Now, the most important thing to understand here is to understand that the spine, the pelvis, and the limbs are a single unit where the weight transmission happens from the spine to the posterior pelvic ring and therein goes to the anterior pelvic ring and goes down along the medial aspect of the proximal part of femur. And it is the mechanical axis of the limb which you identify radiologically, which is the line of load or weight transmission from the axial to the appendicular skeleton. So any disruption of the lumbo-sacral coccygeal functional unit will cause alteration of physiologic loading across the pelvis and physiologic weight transfer from the spine to the limbs, and thereby will have repercussions of gait problems, of posture problems, of sitting ability, and for normal locomotory ability of the patient. And why it is so special? Because if you see the one side of the hemipelvis, the ilium, the acetabular region, and the anterior pubis or the anterior pelvic ring are perpendicular to each other. So this is a three-dimensional, like you see these three rings, these are present perpendicular to each other, and they present a very specific pattern of load transmission. And because this pelvis is closed with multiple osteoligamentous structures, the weight transmission, if it does not happen optimally, like this child whose pelvic injury was treated conservatively, his unstable pelvic injury, the load on both the spine as well as on the hips is very, very significant. And if you see this X-ray, which is 5 years after the incipient initial injury, this patient has a scoliosis, has a fixed pelvic obliquity, has a limb length discrepancy, has avascular necrosis of both the hips, and has a symphyseal disruption. And this child who sustained his injury as a 14-year-old, at 19 or 20 years of age, he's unable to walk comfortably, he's unable to sit, and he's unable to perform his activities of daily living. So here lies the importance of understanding that the posterior pelvic ring, if you follow my cursor, is extremely important in the weight transmission from the axial to the appendicular skeleton. And what happens is that in double leg stance, the posterior part of the pelvic ring is subjected to compressive forces, and the anterior part of the ring is subjected to distraction forces. And as Vivek so beautifully showed us so many examples of why inadequate and unstable fixations will cause the pelvis to start loosening out or the fixations to start loosening out. And that is because in double loading or double leg stance, there is a lot of distractive forces acting on the pubic symphysis. Now, the first thing to identify is in sacral fractures is basically to be able to diagnose them. And to diagnose them, one has to do a classification, because sacral fractures can be broken. The sacrum can be broken longitudinally on one side, transversely. There can be avulsion fractures, or there can be a combination of longitudinal and transverse fractures resulting in various different shapes, like the H-shaped fracture, the U-shaped fracture, the lambda-shaped fractures, and these present with very specific entities of spino-pelvic dissociation. Now, what the classifications tell us is extremely important about the character of the injury. But what the classifications also do not tell are certain very critical elements which affect the treatment of the patient. And those are neurologic status. So there are, other than the single out classifications, the normal classifications do not tell us about the neurological status of the injury. It does not tell us about the bowel and bladder issues, and the classifications do not throw any light on soft tissue damage. Further, these classifications do tell us a lot about instability, and there are certain modifier classifications like the Eisler scale and the Roy-Camille classification of zone 2s of the posterior pelvic ring injuries, sacral fractures, which tell us about the degree of instability. So let's talk about the sacral fracture classification, and the one classification that is very prominently discussed across the platform is the Denise classification. And basically, he has described the longitudinal sacral fractures as zone 1, if they pass lateral to the neural foramina, zone 2 if they pass through the neural foramina, and zone 3 if they pass medial to the neural foramina. And this is the sacral fractures happening on one side. In addition to that, you could have bilateral sacral fractures also, and those add to the degree of instability of the posterior pelvic ring. The important thing to understand about Denny's classification is that it is a good neurologic guide to, whether the neurology is going to be affected or not affected in sacral fracture morphology. But it is a very poor guide to instability and to any kind of soft tissue injury that may have happened. So let us talk neurology in sacral fractures. It happens in about 50 to 60% of the sacral fractures. And neurologic injury in sacral trauma is a very significant cause for reduction in quality of life. The neural injury can happen because of direct compression or because of overstretching. And this neurologic injury correlates with pelvic ring stability more than the geometry of the sacral fracture. And that is very important. So if you see unstable pelvic injury, so consider that zone 1 fractures are associated with unstable pelvis injuries in about 33% of the cases, zone 2 fractures in about 43%, and zone 3 fractures in about 64%. And the bilateral sacral fractures have about 79% of unstable pelvic injury. So obviously, the neurology is very important, and it tells us a lot about pelvic ring stability. And why are we talking about pelvic ring instability or stability? And that is because when you define whether a patient needs an operative treatment or not, there are 3 very important things that you have to assess. First is the grade of instability of the pelvis. Second is the degree of fracture displacement. And third is the sacral fracture related nerve injury. So what are we talking here? Let's consider this 36-year-old male who had a road traffic accident for a polytrauma, sustained a combined pelviacetabular injury. And what we are going to do here is concentrate on the transverse or the oblique fracture below S3 or S2. So these are injuries which are called type A injuries. These are transverse sacral fractures and coccygeal fractures. And these are by definition those injuries which do not need surgical treatment. Obviously, this patient underwent some surgery, but it was not for the transverse sacral fracture. It was for the other injuries which were associated. Another patient, a 16-year-old male, a pediatric pelvic injury patient, had a road traffic accident, sustained a polytrauma situation, and had a floating hip, which means had a pelvic injury or an acetabular injury associated with injury to the proximal femur. These again are zone 1. This patient had a zone 1 injury. And again, these zone 1 injuries which are not displaced are the ones which do not need surgical treatment, like you see this second proximal CT scan. However, if the patient has a bilateral zone 1 fracture, that can be a cause of increasing instability, and those are the ones which will need surgical stabilization. So this patient underwent surgery for his injury to the bilateral pelvis and also to the acetabular fracture. Another patient had zone 2 injuries, and this is only to reiterate that surgery is only to be done when there is a neurologic deficit associated, because that adds to the degree of pelvic ring instability. So another patient here who underwent surgical treatment for the same, and this time the way we do the posterior tension band fixation, and we published on this very recently in EJOST, that you can actually do what an iliosacro-sacroilial screw does with a tension band plate, And the way we do it, we are able to get 2 screws across the sacroiliac joint on both the sides. Thereby, it's a much safer fixation. It is a very minimally invasive fixation because we use just 2 posterior 1-inch incisions, and it gets done very fast, and you can do this within 40-45 minutes. So another patient, another situation where this is a 38-year-old young male, motor vehicular accident, and who had significant amount of hemodynamic instability, also had a blunt injury abdomen, also had comminuted shaft femur fracture, and had unstable pelvic ring injury on the right side, and had disruption of the symphysis, low anterior column. And these are patients who very often require ICU care before their actual pelvic injury can be treated. And once these patients stabilize, then you need to look at their bony injury. And once they're okay, their bony injury needs to undergo stabilization. And it is very often that certain posterior pelvic injuries, like Vivek said, require anterior ring stabilization as well for the overall stability of the pelvis, so that once the injuries heal, the pelvis is stable and can take the physiologic load of walking, of sitting, and of activities of daily living. Now, defining stability in sacral fractures is very, very important. And there are certain modifiers and classifiers which help us to define them. One is the Roy-Camille classification, and the other is the Eisler classification. Now, the Roy-Camille classification basically talks of unstable pelvic injuries, where type 1 just has a kyphotic injury. In type 2, there would be a significant kyphosis because of anterior translation of the sacral fracture. Type 3, there will be an overriding. And in type 4, there will be a buckling or a collapse at the level of S2 or S3. And several of these injuries are those which have both vertical as well as horizontal fractures. For example, this is a U-shaped fracture where there is a dissociation between the spine and the sacrum and the remaining sacrum and the pelvis. The H-shaped fracture, again, where there are 2 vertical fractures which are connected by a horizontal fracture. The lambda or the T-type fractures based on where the fracture is in the vertical and the horizontal limb. Now, another important classifier of stability or instability of the spine, especially for zone 2 fractures, and zone 2 fractures, if I can remind you, are the ones which are vertical fractures going across the neural foramina. So those zone 2 fractures which go lateral to the facet are type 1, which go through the facet, add increasing amounts of instability. They are zone 2, they are type 2. And those which go medial to the facet joint, they also add increasing amount of instability to the zone 2 injury and the posterior pelvic ring, and they are type 3 fractures. And very often, very innocuous looking fractures, which somebody might leave untreated, they actually need surgical treatment, because they may be going either through the facet joint, destabilizing the spinopelvic junction, or they may be going medially, which are going into the spinal canal. Again, they can cause significant destabilization of the spinopelvic junction. Again, as a similar example, this very young 14-year-old girl fell from a height, 12 feet, and had an L1 burst fracture, an L2 lamina fracture, had an S1 to S3 fracture and neurologic injury, and also had injury to the forearm. And if you can see my cursor, she had a type 3 unstable, Roy-Camille type 3 unstable pelvic injury. So what did we do? And she had an unstable L1 burst. So she underwent surgical treatment for her spine as well as for her lumbopelvic injury. And we did a lumbopelvic distraction and fixation with a lumbopelvic fixation for her, which eventually she took out. And in 8 months, this child recovered her full power, her full mobility, and full bowel bladder control. So these are injuries sometimes which are associated with neurology and bowel bladder dysfunctions. and sometimes optimally treated and then treated on time, these children or these patients do extremely well. So what do we take home from today's talk? The key take-home parameters are that do not look at the sacrum or the pelvis in isolation, because whenever there is the pelvis and the pelvic ring never breaks at one point. So whenever you see a break in the anterior pelvic ring, always suspect that there is something happening to the posterior pelvic ring. And also do not treat the pelvis in isolation. Also consider what is happening to the spine, and also if there are associated injuries in the lower limbs. So the lumbosacral coccygeal functional unit is a very important structure for the structural and the functional integrity of the spinopelvic and limb weight transmission zone. And what decides whether somebody needs a surgery or not is whether there is an instability of the pelvic ring, what is the amount of fracture displacement, and whether this sacral fracture is associated with a neurologic injury or not, because neurologic injuries add to the degree of instability. The second take-home point, Denise classification is an excellent classification for sacral fractures. It tells us about neurology and instability, but it does not tell us anything about fracture displacement. Also, it does not tell us anything about the degree of soft tissue involvement. So you have to factor in these other two parameters before you take a final decision on what needs to be done for a Dennis zone 1 or a zone 2 or a zone 3 fracture. The third message from today's talk is that spinopelvic dissociation is a significant injury which leads to instability of the posterior pelvic ring. And a modified Roy-Camille classification and the Eisler classifications are very important to define pelvic instability. And a lot of these patients will need not only lumbopelvic fixation, but a triangular osteosynthesis where you have lumbopelvic fixation on two sides and either a tension band plate or your iliosacral screws on one side. Eisler classifications are important because they further quantify the degree of instability caused by zone 2 pelvis injuries, say Dennis zone 2. They tell us about neurology and the degree of instability, but again, they do not tell us anything about degree of displacement or soft tissue involvement. And this is perhaps the only classification which tells us about the degree of neurological deficit, and that is the Gibson's classification, where if there is no neurology, it is a type 1, where there is only paresthesia is a type 2, where there is only lower extremity motor deficit, it is type 3, and if there is bladder bowel involvement, that is a type 4. And these basically are in increasing order of severity of the neurologic injury. So thank you very much for your time, and extremely grateful and a lot of gratitude to Professor Al-Shahab for inviting us for this talk, and you're welcome to ask your questions. Thank you very much, Egyptian Orthopedic Association.
Thank you so much, Professor Abhay. It's an honor for us, sir. Your participation is a great honor for us, sir. Thank you so much. And I hope to see you again and again. Of course, in the upcoming conference of the Egyptian Orthopedic Association, you will be with us, sir.
Thank you so much, sir. Thank you for inviting.
It will be a great honor for us, sir. We have many questions from our dear attendees. If you please allow me to ask questions.
Sure, sir. Sure,
First question from Dr. Gamal Qasim. What's the maximum time delayed before fixing sacral fracture? Can neurological deficit be assessed intraoperatively?
Yeah, so neurological deficit is usually to be assessed preoperatively, unless you have a caudate Weiner syndrome, which will definitely, the patient will present with the neurological changes earlier on. And very often, subtle neurological deficits are present, like toe drops or ankle foot drops, and these need to be assessed with a very careful and meticulous examination. Of course, you will not be able to examine if your patient has an injury which allows a decomposition of his GCS. So those are very difficult situations, and those are situations which need to be handled carefully. Sacral fractures, there is no given time to when you can treat them, but they need to be treated once the overall patient stability is there, once the patient is resuscitated, and your intervention will not cause a second hit, and the life-threatening injuries need to be treated first.
Yes, sir.
So the
Thank you, sir.
cardiac venous syndrome is the only thing which needs to be treated as an emergency.
Yes, sir. The next question from Dr. Muhammad Yasser. Any tips for wound care after posterior approach to the sacrum? And do you get a lot of post-operative wound complications, sir?
So wonderful, and so thankful to you, doctor, for asking this question, because we've recently, as I mentioned, published in eJost about our technique of minimally invasive technique of tension band fixation for the from the posterior aspect. And how we do it is that we make a small osteotomy on the posterior superior iliac spine, and we bury the plate inside, and over the top we put the bone graft that was taken off while performing the osteotomy, and we fix that with a periosteal suture. And thanks to this approach, we've had only 2 or 3 wound dehiscence in almost about 60 or 65 posterior fixations for the sacral fractures with this approach. And there is nothing extra that we do for them except put them on a water mattress and get them in bed mobilized as soon as the fixation is done.
Yes, sir. The next question from Dr. Muhammad Salah. Tips and tricks for spinopelvic fixation.
So if you are an orthopedic surgeon trained in spine, you can do it yourself. If you're trained into spinopelvic fixation, you can do it yourself, or you can ask a spinal colleague to come with you. The only time to do spinopelvic fixation is if you have a vertical fracture of the sacrum, which is accompanied by a horizontal fracture, and especially if there are bilateral vertical or longitudinal fractures which are connected with a horizontal fracture. So what that does is that it dissociates the spine from the pelvis. And once that happens, your fixation needs to go to the spine as well as to the pelvis. So very simple. If the degree of instability is higher, you can do 2 levels of spine fixation and a single iliac screw with a connecting rod, or with a triangular osteosynthesis, or you can do a single level fixation depending upon the degree of instability.
Yes, sir. The next question from Dr. Hamza Masoud. Is there any precaution in cases with severe scoliosis with pelvic fractures?
Unless you have to treat the spinopelvic junction with a fixation, I do not see there are any major issues in scoliotic patients with the pelvic injuries, and especially posterior ring injuries, except of course if you have a patient who has a very severe structural scoliosis, which you might look at addressing at the same issue in a youngish patient who has a symptomatic problem.
Yes. The next question, sir, from Dr. Muhammad Sayed. What is the indication of tension plate versus spinopelvic fixation?
Yeah, so spinopelvic fixation is done for increasing levels of instability where the spine dissociates with the pelvis. And why does that happen, as I mentioned earlier also, is when you have 2 longitudinal fractures through the sacrum and they are connected with horizontal fractures of the sacrum. So the spine and the pelvis lose communication. That is the indication for spinopelvic fixation. But if you have standalone sacral fractures, even if they have some degree of anteroposterior translations, they can very safely be treated with tension band plates.
Yes, sir. Another question, sir. In fracture sacrum with bowel and bladder affection, whether we need posterior decompression or fixation only will be enough?
So in case there is a neurologic injury of a zone 2 with an impinging fragment, there is usually not a very strong indication for decompression. And if there is an impingement, then decompression will help. However, it has been observed and is published in the literature that very often the degree of recovery of the neurology is only up to grade 3 with even the decompression.
Yes, the last question, sir. Differences between screw fixation versus tension band in sacral fractures?
Yes, so you have to understand that what are the two types of fixations doing. You can do your iliosacral screws also in a minimally invasive fashion. It can be done for isolated SI joint disruptions or for bilateral injuries where you do a ilio-sacro-sacro-ilial fixation. The tension band fixations is the one very major difference is that the margin for error in an iliosacro-sacroilial screw fixation or an iliosacral screw fixation is very, very less. But if you do a tension band fixation, you can do both side SI joint fixation, especially with the technique that we've published. And it's a straightforward job, no neurology involved, no hassles anywhere, and you can very comfortably get out with the same quantum of fixation.
Thank you so much, Professor Abhay, for this very, very interesting presentation about a very important topic. Thank you so much for being with us, sir.
Thank you so much, sir, for having us. Thank you very much.
I hope to see
very
you
grateful.
in Cairo soon, sir.
Very soon, sir. Surely. Thank you so much for
Thank you so much, sir. Thank you, sir. Our next speaker will be my dear friend and my dear brother, Professor Walid Kashta, the head of the orthopedic department, McMaster University, Canada. Professor Walid, thank you so much for being with us. It's an honor. Professor Walid,
yes,
it's obvious now. The voice is obvious now.
Yeah,
Professor Walid will speak about pelvic osteotomies. I'm very happy to see you again, sir.
Yeah, thank you very much, Dr. Mohammed, and thanks for all the amazing faculty and beautiful lectures and presentations. Although my presentation will be a little bit different than the other talks. Hopefully we can make some interactive presentation, which is the way I would prefer. So feel free to type down and make sure you type fast so we can go through all the questions while we're talking. So we're going to talk about pelvic osteotomies, and I do pediatrics from day 1 to the age of 18. So pelvic osteotomies can even be done even over the age of 18, but I'll try to focus at this age group. So the first question, and I would love to see some comments, why do we perform pelvic osteotomies? Or in another way, what would be the indications of pelvic osteotomies?
We can put our answers in the Q&A or in the chat box. Yes, Dr. Ali is saying DDH and SCAFI.
Excellent.
Dr. Mohammed is saying bladder dystrophy.
Extrophy. Beautiful. For femur head cover, DDH, SCAFI, Berthes. Excellent. Hip dysplasia. That's a very good start. I would add hip dysplasia due to syndromes or dysplasia or cerebral palsy, as it's one of the common things we do pelvic osteotomy for. But I'm glad there are comments on DDH and Berthes disease. Post-traumatic syndromic is also added. That's amazing start. So usually after we have the right patient for the indication, we do preoperative assessment to get the correct diagnosis. We might not be able to know the syndrome behind the case. Then we can send for genetic assessment. We make sure we assess the patient from head to toes. We look any facial asymmetry or dysmorphism. Look for any other abnormality in the limbs, and do assessment of the patient gait, get a diagnosis, get classification, and then we'll think about the type of pelvic osteotomies. hip dysplasia, also get the diagnosis and classification, what type, early onset or adolescent, and then we do radiological assessment of the hip dysplasia and do planning and surgical decision making, how to decide which type of pelvic osteotomy we would like to perform, which is a common question every time people ask the same question. What's the exact pathology and what needs to be corrected? So if the acetabulum is affected, what exactly needed to be corrected? So is it the male direction of the acetabulum, directed more superior or more coverage, or malrotation, retroverted, anteverted, deficiency anterior, deficiency posterior wall? Is it a small acetabulum? Is it big femoral head compared to the acetabulum? All these questions would like to answer in our assessment. Dr. Wedge in 1997 mentioned that it's not just malrotation or maldirection. There is also marginal erosion, torsion, hypoplasia, abnormal shape, and decreased acetabulum surface area. And part of the acetabular osteotomies or some certain types of them can increase the acetabular surface area or decrease acetabular surface area based on our technique. What are the consequences of untreated hip dysplasia? And in this slide, I focused on hip dysplasia because it's the most common one that needed pelvic osteotomy. So 20% of the total hip replacement performed, and we have amazing adult faculty who can confirm that are under the age of 50 are due to hip dysplasia that probably untreated or had some sort of complications. And the survival of total hip replacement after DDH is the lowest. It's more inferior than hip replacement after regular osteoarthritis. That's mainly because of the increased risk of dislocation during the first 6 years or 6 months post-operative. So what are the broad classification of different types of osteotomies, which is kind of, some people like to talk about this, is that 3-directional osteotomies, reshaping osteotomies, or salvage or augmentation osteotomies. And apart from salvage or augmentation osteotomies, I would say redirectional or reshaping, based if we achieve the goal, there is no big difference if we can achieve the goal that we needed. So the redirectional osteotomies are the osteotomies that need a complete cut of the pelvis, and then you need to move the pelvis in a direction that you can get the achieved coverage, especially for the acetabular index and the CA angle, and use certain hinges based on the age. For example, Salter osteotomy is one of the redirectional osteotomies that depends on hinging on the symphysis pubis. So every time children grow up, as the symphysis becomes narrower and less hingy or less mobile, doesn't give you the desired correction. Some people say you can do it up to age of 8. Some people say 10. Dr. Salter has some sort of delayed Salter osteotomy. You can do it around the age of 12 with very good results, but I found that it works in his hands way better than others. So this is a kind of type of redirectional osteotomy. Although when kids grow up more and there is no much hinging at the symphysis pubis, then we need to do something else so we can get some movement to achieve the coverage. That's why people start to talk about triple osteotomy or Gans PAO osteotomy. While the reshaping osteotomy, it's kind of name that came from just doing partial cut and hinging on mostly the triradiate cartilage if you do it early, Again, under the age of 8 works well because the trihydrate starts to become thinner, then you don't get enough elasticity to bring it down, and that's typically the DEGA and Pemberton osteotomy. Salvage or augmentation osteotomies, which we can argue with this name as a salvage, although this classification is just to make it easy to understand or imagine the different types, but it's usually purely talking about shelf and carry osteotomies. In these cases, people consider it salvage because you don't actually cover with the true cartilage, but you cover with bone that transforms into fibrocartilage in the future. So we start with Salter osteotomy, and with the picture of Dr. Salter. Goals of the treatment is to normalize the acetabular index. It can get up to 10 degrees. Dr. Salter said he can get up to 20, but not most of the people able to get this more than 10. C angle improvement of 10 to 12 degrees. So the goal is to minimize early onset degenerative changes of the hip with the prerequisite of this is done for the concentrically reduced hip. So the hip has to be already reduced and you achieve the cover. The Salter osteotomy wouldn't reduce the hip, the dislocated hip. Contraindications, which is actually Dr. Salter mentioned this, in case of posterior acetabular insufficiency, especially in neuromuscular hips. And so in CP, almost more than a third of them has posterior insufficiency. So when you do Salter osteotomy with the goal of anterior coverage, you're actually doing more posterior insufficiency and increase the uncoverage of the posterior wall. So that's why it's not indicated. Also contraindicated in hips that's not reduced. How we do Salter osteotomy. Salter osteotomy is very straightforward. So your incision will be the Smith bead incision through bikini incision, which is modification done by Dr. Salter. And the bikini incision, your landmarks is 1 finger breadth lateral to the iliac crest, and it's oblique through the crease. And you direct it from superolateral to inferior-medial. And if you follow my cursor, you can see the line of the incision. There are different types of landmarks. Some people say ACES to the tip of GT and go in between them. My preferred way is to make it similar to bikini, so it can be cosmetically accepted. The internervous plane, initially, after either you look at the lateral cutaneous nerve of the thigh. I don't waste time, so I go laterally through the fascia over the abductors with interfascial plane between the sartorius and the abductor. And then we'll go deeper with the retractors to the rectus femoris, and the interval will be between the rectus and the gluteus medius. And then you will see the capsule directly underneath. Then we will do our open reduction. We'll focus here on the osteotomy part. Then split the apophyses. Two ways to split the apophyses, either central at the iliac crest, and you go superosteal in both directions. Be careful of bleeders coming from the bone. I use bone wax to stop the bleeders, and also lots of padding with a sponge. Make sure you count the sponge, and then we'll go add the greater cytic notch to use certain homins. With the homins, make sure I'm purely superosteal for safety. The greater cytic notch has 13 structures that are all vital. And the best way and safest way is to pass jiggly saw, and the direction will be between the anterior superior iliac spine and anterior inferior iliac spine for the direction of your cut. Once you make your cut, most of you use a towel clip to get the distal piece of the bone to be directed laterally and anteriorly and distally. So can get the coverage that's required. You get the bone graft from the iliac crest and add the bone graft at the triangle that you created. Make sure the iliac prim is in line, not displaced, so can maintain the pelvic canal. And then use pins. Dr. Salter likes the threaded pins to fix for Salter osteotomy. Need to immobilize patient in a hip spica for about 4 to 6 weeks, and then pins has to be removed. It's kind of another minor procedure surgery in about 6 weeks. The achievement from Salter osteotomy, again, you can get 10, 15 degrees, maybe 20 degrees with certain hands. It covers the anterior mainly, and so it's mostly indicated for hip dysplasia that has anterior wall deficiency, and it's contraindicated for neuromuscular conditions that usually have the posterior wall deficiency. Here is an example of whenever it's indicated, it's beautiful, and whenever it's well done, maintaining the pelvic brim intact, it's beautiful, and then you remove the pins in about 6 weeks. So what happened for a long time post-operative? All the studies showing that if you have a perfect congruent reduction and no complications happened after Salter osteotomy, then you can get excellent results in about 30 degrees. How about the retroversion, established retroversion after Salter osteotomy? There is a lot of people think it can cause retroversion, although the study shows so mostly the retroversion with the acetabulum is a result of intrinsic development of the pelvis in each patient, although it's not consistently caused by Salter osteotomy. Then patients get older, and Salter osteotomy doesn't really work in my hands after the age of 8. Then whenever I need to do an osteotomy, I start to think for another type of osteotomy, either one of the reshaping, if I'm happy with the triradiate cartilage, or I switch to the triple osteotomy, which is still one of the redirectional osteotomies. So the triple osteotomy, instead of depending on the symphysis pubis as a hinge, they made or created their own cuts. So one superior pubic ramus cut, one ischial cut, plus the similar Salter cut. So start by the iliac cut, as you see here, number 1, and then you do the second cut at the pubic ramus. So you need to extend your incision. It's exactly the same approach, but to extend the incision more distally, making sure you protect the neurovascular bundle and get the superior pubic ramus cut. And then I do this through the same incision with the rectus sparing, and then you do the ischial cut. Locure and Tunis and Steele, all three triple osteotomy. The difference are the level of ischial cut. So with Locure did osteotomy the ischial cut more distal and medial. Steele did it a little bit at the middle of the ischium. And then Tunis said, I want to skip the sacrospinous ligament because it might affect my desired redirection and correction. So he made it super close to the acetabulum. This way, Tunis usually get more freedom to get the redirection and correction. And I heard from Dr. Parsh that Tunis was a friend with Gans, and that's why over time Gans from Tunis developed the idea of the Gans osteotomy later on. There is another view of how we do the triple osteotomy. So your cut starts just below the ASIS or between AIS, and your direction usually towards greater sciatic notch. Of course, we need to protect it subperostally. And then we do the superior pipocremas cut. Typically, you have to protect with 2 homens. Sometimes I do use a sharp homen as a retractor, so I use the hammer, get the sharp homen distal to the desired cut for the superior pipocremas, and I use it to protect the soft tissues, and then I get 2 homens underneath. You can do only 1 cut at the superior pipocremas, or you can do a kind of V cut. I like to do only 1 cut. I use a Gonzo osteotome because it can give me a nice angle. And then the ischial cut, I do it through the same incision. I go at the inferior medial aspect of the capsule, and there is a soft spot. So you use the Mayo scissor to dissect the soft tissues, and I go through the soft spot until I feel bone, and then with the X-ray, I mark the infracotyloid fossa, and then we get the cut as high as I can below the acetabulum, so I can simulate tunis. Once we get the tunis or your 3 cuts done, then you get the desired correction. I use a Shan's pen and 1 or 2, and with the 2 Shan's pen, I direct it. In a way, I get the desired coverage, either anterior or just lateral, and try to avoid the retroversion of the acetabulum because this is a common complication or technical mistake. Indications: symptomatic hip dysplasia, C angle of less than 20 degrees, acetabular index more than 40 degrees, but the head has to be spherical, so you can rotate the acetabulum on a spherical head. Contraindications: tunis, arthritis grade more than 2, incongruent hip joint, irreducible hip joint, and significantly reduced range of motion for less than 70 degrees. Which I've seen it. I ignored this contraindication once, and I regret it now because that patient is not doing well. What are the dangers or complications of triple osteotomy? Is the main one is retroversion of the acetabulum that can cause pain and impingement. Also can cause external rotation deformity of the limb due to uncoverage of the posterior acetabulum. Also, be careful with the nerve injuries, especially when we do the ischial cut. Even with the pubic cut, can go to the obturator foramen. And then Gans developed his osteotomy, and has a lot of similarities to Tunis. And if we focus on the lines here, it's a very complex osteotomy because he wanna cut around the acetabulum without cutting the posterior wall, so can keep it stable, so patient can start early weight bearing and also protect the soft tissue behind the acetabulum. So we'll go back. Here is the lines. Again, that's the same line as the triple or Salter, but it's incomplete. So you stop 1 centimeter if we look from inside. We stop this cut 1 centimeter more anterior than the pelvic brim. And then the other cut for the superior pipocremas, which is exactly the same as the triple osteotomy, and it's a complete cut. And then the third cut is ischial cut, similar to Tunis, but it's incomplete. So incomplete kind of Salter, incomplete kind of Tunis, and complete one of the triple. And then the tricky part is to get connecting this incomplete cut to this incomplete cut through one vertical cut, protecting the posterior one not to break through, and also not to go through the joint and the acetabulum. It's also, once we get the bone freed, tricky to avoid the retroversion, so you have to be careful. It's a very powerful osteotomy. It can get you correction of what you need. This is the strongest and the most powerful osteotomies that give you the desired correction. So here's again, some people go higher whenever the acetabular dysplasia is more severe, but it's beautiful when you go a little bit lower, and it's easy when you get the correction, especially the vertical cut is a little bit painful. So here is the shape whenever you finish your cut. So acetabulum is completely free, although the posterior wall is intact. How's the approach? Same approach. I like the single approach. I use the bikini incision as well with a Smith bead. Some people use the traditional Smith bead incision, but I found the bikini is fine. I used to get the sartorius completely detached from the ACES. Initially, I used to cut the ACES bone and fix it, but I don't have to do this anymore. The most important thing is I have to protect the angular ligament. If any injury happened to this, you can cause femoral hernia down the road, and if it's incarcerated, it's very dangerous. So I go through the ACES cartilage and peel it off with the osteotome, and I take the sartorius with it to go medially, and then I get the same intervals. Again, go to the rectus. Right now, I use the rectus pairing technique. Then again, I go through the medial wall of the capsule. And so the most inframedial wall, this will give me access to the ischium. So again, spread your Mayo scissors and then use a cob, create a space, put the Gans osteotome inside. I look with the fluoro. I know some people don't, but fluoro is helpful, so you can get the ischial cut. I do a lot of dissection at the internal iliac surface, so I can get inside all the way down to the superior pibocremus from here. Again, I use a Homan, a sharp Homan, as a retractor, and I use two Homans, blunt Homans, to protect the obturator foramen. And then I do the complete cut. Again, incomplete cut as a Salter or triple, and then through this inframedial border of the capsule, then I get the ischial cut like this. Beauty of the Gans osteotomes, it's angled, so you can get you the desired angle you needed. So get the direction for the incomplete cut, do the superior cut, and then connect them, making sure you don't go to the joint and you don't break onto the posterior column. Again, when I do the reduction, use a Shan's pen and one or two while you do a lamina spreader inside all together until you free it up, and then you get the desired correction. Mostly you get distal and lateral. So either can get more anterior, posterior. Make sure you adjust the rotation and avoid the retroversion while doing it. Best way is to get internal rotation before you do your desired correction. This will help you avoiding it. So again, difference between Tunis and Gans is Gans made all the way to protect the posterior column. PO advantage, leaving birth canal unaffected, soft tissue protection, and a stable pelvis that enable rapid mobilization within a week. I'm still doing two touch weight bearing for 6 weeks with either Tunis or Gans. And here is after you remove the piece. This table shows you some of the indications and the desired coverage and where is the hinge, degree of correction, and the expected FEI in the future with all of them. Feel free to take a screenshot, and it's a very nice table. We'll talk about all of these while we did the presentation. We're still going to talk about the reshaping osteotomies, which is, again, it's incomplete osteotomies. Depends on the radiate cartilage that has to be open. I would say maximum age is 8 to 10, although in cerebral palsy, some people do it in adolescence. They depend on hinging on the bone instead of the triradiate cartilage, so I consider it's a different category. Pemberton osteotomy, it's a beautiful osteotomy. The difference between Pemberton and Dega is you go through the lateral outer table, inner table. So your start point is actually anterior above the AIIS, and then you make it curved beautifully around the acetabulum. It's incomplete cut. so you don't go through the thyroid cartilage and avoid injury of the thyroid cartilage. Make sure you get enough thickness, so don't go very close to the joint, so you don't injure the joint. And overcorrection can cause femur head impingement, and it's very powerful. And be careful. Sometimes you feel like, wow, I can get amazing correction, but anytime we exaggerate things, we get complications. Also, premature closure of the thyroid cartilage has been reported, and also it can cause transiliac lengthening of the ipsilateral limb by the open wedge. Again, you get the graft, triangular graft from the iliac crest, ipsilateral side, and you impact it there. It's a stable osteotomy, so you don't need bends, which is one of the difference from Salter osteotomy. Here is it after you open, and after you put the graft in this picture, the added bends, I don't. There is another example on a case that's beautiful when you do the Pemberton osteotomy, and you get amazing coverage, and it looks, compared to Salter, it looks more beautiful when you get a curved shape of osteotomy around the acetabulum that looks matching. Dega osteotomy is actually can get the same power of result of Pemberton, although the technique is different and it's more versatile. So you can get more anterior coverage if you want, more posterior coverage if you want. So you go across the pelvis from anterior to posterior. So mainly you get the outer table of the pelvis, and I start my cut at the center, and when we go with the X-rays, I start at the center part here, and then I get curved osteotome directed all the way towards the thyroid cartilage. I stop half centimeters above the thyroid cartilage to avoid injury, and I open more anterior and I open more posterior. I use the Carrison. If you're familiar with the spine, so you can cut a piece of posterior column and a piece of the anterior column, and that's people call the San Diego modification of Dega, just by doing these two cuts, so you can get more easy opening laterally. Then you put your graft as desired. If you need more anterior coverage, you put the graft more anterior. If you need more posterior coverage, you put the graft more posterior, which is usually what I do in cerebral palsy. So salvage or augmentation osteotomies, we're coming to the end, and there are two, Chiari or shelf osteotomy, and they're usually whenever we're not able to do a reconstructive surgery, although I rarely do Chiari now because of the guns usually has a very powerful coverage. But again, Chiari, you go so close to the acetabulum, but not into the acetabulum, and you do a horizontal cut, and then you displace it in a way to get head coverage by the rest of the iliac bone, and you do bend on the fibrocartilage transformation after. It's very powerful and can get you coverage in cases it's hard to cover, especially some cases are a revision after a PAO, or cases that similar to Down syndrome or trisomy 21 that you get multiple recurrence after. It might be a good option as a salvage at the end. Gives them a good coverage and protects the labrum, and it's excellent for weight bearing. Shelf acetabular augmentation is another way that's considered as a salvage, and the way we do it is we make multiple drills over the capsule, and I get the bone graft from the iliac crest, from the inner table. Then I make multiple holes so you can pass sutures and suture it to the capsule, and you get the smooth surface towards the capsule, and the rough surface above towards the iliac crest, and then you can get some bone graft around it. It's a very powerful as well, and give you a very good coverage. I use it mainly purely for birthes. So when you have a coxa magna and small acetabulum, it's a good option. We'll go to the fun part, some case presentation. So 21-month-old with a hip dislocation in the left hip. So I will leave it to the audience. You can get your comments and what will be your favorite treatment.
You can write your comments in the question and answer box or the chat box.
While writing, I see a question from Dr. Gamal Qasim. Can pelvic osteotomy be done in concomitant with lumbar arthrodesis to restore scoliosis? So it's the typical example is a neuromuscular condition that usually you go from T2 to pelvis. Whenever they have a hip dislocation, we prefer to go with the spine first because we can correct the pelvic tilt. And then actually some of them don't need a hip osteotomy after. But then if we need it, it's going to be easier with horizontal pelvis compared to oblique pelvis. So Dr. El Sayed, open reduction, perfect. And what type of osteotomy would you do? Perfect. So Dr. Shakib said open reduction, Salter osteotomy, and may need femoral shortening. I measured the acetabular index here was about 38. So if you have a very good experience with Salter, can get this down to about 15 degrees. Yes, Salter is good. Otherwise, Pemberton or Dega can be very powerful to get the acetabular index down. Of course, we have to do open reduction and make sure the hip is reduced and stable first. And pelvic osteotomies don't help us to get the hip reduced, just to be mentioned. There's a question from Dr. Muhammad Osman. Do you believe to identify the osteotomy type after initial reduction and identifying the direction of stability and based on decide which osteotomy to be done? Number two, does the triple or Salter osteotomy disrupt the Shenton's line? So for the first one, actually I made it easy in my life. So I switched from all the osteotomies to focus on Dega osteotomy. And Dega osteotomy, if I need to do more anterior coverage, I put the graft anterior, more posterior coverage, I put posterior. If you want to make a good balance, I put both anterior and posterior. But yes, if you like to do a Salter this week, like to do Pemberton next week, like to do Dega the third week, I'm too old for this, then you can decide intraoperative. Does the triple or Salter? No, that doesn't disrupt the Shenton's line. And usually it makes it, actually, when you do a good reduction, the osteotomy doesn't disrupt the Shenton's line. Is this pre-operative versus decide to which osteotomy or intraoperative? Yes, it's you can do that. I don't. The only changes intraoperative because I do Dega now for all my practice, and so it makes me change the decision to add more anterior coverage versus posterior. So we actually did the open reduction first, but the hip is dislocated while we're doing the Dega, and then we get correction done, and then the bone graft has been inserted. Now we didn't need to do femoral shortening in this case, but it's beautiful if you need femoral shortening, as you can use the part from the femur as a bone graft, and it looks like a nice circle if you put it as a circle, and if you put it horizontal, it's okay. And here is a patient in about 9 months post-operative. Any questions about this case?
What, Dr. Walid, what do you do for changing for the proximal part of the femur?
For changing?
Yes, there is sometimes you have a changing, like you look for the neck of the femur. It's become broader.
Yes. Oh, if the postoperative changes of coxa magna or wide neck. Is that correct, Dr. Kurna? Yes. So mostly postoperative changes I see, very commonly you see changes in the proximal femur, and that's, in my opinion, it's postoperative changes because of the blood flow, and they get the hyperemia that causes more growth, and the majority of them remodels to normal later on. But if it's a part of EVN or growth abnormality, I'll keep monitoring these cases, and I follow the Kalamshi-Salter classification of EVN post DDH. And if it's type 1, usually I don't need to do anything. If it's type 2, sometimes you get subluxation around the age of 11 or 12, then I do guided growth early, or I do varus osteotomy at certain stage. And if it's type 3 guided growth for me and maybe GT apophysedesis, type 4 usually is the most difficult one. Might only do the minimum for the type 4 or no surgery.
If you're facing cases with increased antiversion or retroversion after you do DIGA and overreduction, do you interfere or just wait and see?
So it's very rare I do this, the derotation, and most of the cases I've done derotation were syndromic, or they have Ehlers-Danlos or significant antiversion that's really affecting the range of motion after reduction with the safe zone. It's actually an excellent question, Dr. Baha, as I'm presenting a case now after this. Has a rotation, and it's beautiful for the argument of the need for derotation to do it. I don't do it routinely because I believe antiversion is normal at this age, and if I'm happy with the hip reduction and there's no extreme movement that affect the hip stability, I wouldn't do it, and they improve. It's similar when we get patients with femur antiversion and in-towing, and we tell the parents, no, this is going to be excellent, the future, 95%. Although some certain syndromes, I felt like the rotation is really affecting the stability of reduction. So these are the kids I would do derotation at the same setting.
Thank you.
This is a 17 years old female with Charcot-Marie-Tooth disease and came with bilateral hip pain and bilateral hip dysplasia. What would you be your suggested management? You can type your comments. Salvage, Dr. Yasser. Yeah. Although can also argue can do hip replacement instead of salvage. She's very active, and she was going to engineering. So I did MRI to make sure there's no osteoarthritis, to make sure in case if she prefers reconstruction that she can be indicated. Triple osteotomy can work. Salvage shelf. I feel like her uncoverage is significant. I'm not sure if shelf at this age would help her, but it's an option. Shelf or Chiari. Containment by shelf and concern with femur antiversion. That's a good point. Redirectional osteotomy. Yes. Which type of redirection, Dr. Ayman? I don't think Salter would work at the 17. So her symphysis is very narrow. So it's either triple or GONS.
Guns.
Yeah, so I discussed all these options with her. She's very smart. She said, let's try GONS osteotomy. And question is to start with the femur. She might need femur varus derotation. As Dr. Bahat mentioned, these are the cases I have low threshold to do derotation if needed. In her case, I said, let's start with GONS osteotomy because she needs a stabler coverage for sure, and this might give her good coverage. And then when I started with the GONS osteotomy, I achieved the coverage that we needed. Then I opted on doing varus osteotomy and derotation. The other reason is with Charcot-Marie-Tooth, you usually have abductor weakness, and whenever we do varus osteotomy, that gives them a very bad lurch, makes them always not happy about it. The other side was done as well. This is first 6 weeks follow-up, but other side did very well. And complication was on the other side when I used 3.5 screws. I'm still at the pediatric mind, so one of the screws or 2 screws broke, and I felt like I lost some of the reduction. Then I did a revision within 6 weeks. Then I used 4.5 screws instead. And here's the pre and here's the post. This is an interesting case, Dr. Baha. So this one presented at the age of 8 was anterior right hip pain and decreased function with the sports. She did MRI. She has been referred to me from the hip arthroscopist, one of our colleagues. He said, that's too young for me. And then the MRI showed anterior labral tear, significant anteversion. She had a significant anteversion. And I believe the anteversion was the reason that caused anterior labral tear. And parents never thought she had any unstable hips when she was born, never had any assessment, but it seems like this is a residual dysplasia with anterior femur anteversion, which is actually bilateral, but she was asymptomatic from left side, but significantly symptomatic on the right side. Also from the MRI, didn't have good cuts of the MRI, so I didn't present it, but MRI shows the anterior labral has tear and also significant anterior deficiency of the acetabulum, plus femur anteversion.
I saw some paper. Yeah.
Yeah, so go ahead.
You can go, what about epiphysiodesis from the inferior part? There's the epiphyseal plate is horizontal, and I can make an epiphysiodesis from the inferior part and leave the other part so it will be covered.
That's a beautiful thought, and I actually discussed this with the family. They were very concerned when I said epiphysiodesis can make some slow improvement, so they preferred something acute because they were concerned about the amount of pain. But it's a beautiful idea. The two concerns with guided growth is when I talked to Jason Howard at New Morse DuPont, he is the most did the guided growth proximal femur since he was in Melbourne, Australia. He told me it doesn't really work after the age of 6 as desired, so some parents get disappointed. And plus, the family wanted to have more acute results because she was in pain. So I actually did your opinion, Dr. Baha, on the left side because she doesn't have pain. So I did inferior guided growth with a screw on the left side because, as you see, she has horizontal physis and also some sort of valgus. So she was going through a caput valga. So I said, let's do a prophylactic work on this one. And then I did the derotation on the right side for the femur, plus some sort of shy dega, more to get anterior coverage with the graft. And she's doing amazing now. And actually, she had Flexion limited to 80 degrees pre-operative, I think because of the labral tear and anteversion. And now she has 120 degrees. She's by herself showing me. She said, "Do you see? I have more flexion now." She came to me last month complaining from left hip pain, and that's that's another problem. These are early X-rays within, I think, 2 months post-operative. But I have a new X-ray. She's still looking amazing on the right side. Left side has a little bit of coverage. She's covered more a little bit, but not too much with a guided growth.
And Professor Walid, you did something for the labral tear?
No. So it was significant. And when I talked to Dr. Ayani's hip arthroscopist, he said, just do structural bony work and mostly you will do fine, which is actually what happened. And he said, if it doesn't work, and then in a year, we can think about something to do. He doesn't like to do scoops under the age of 14 because of the table. So probably if we had to do something, we would do it open to the labrum.
This is a way we can compare both methods.
Both methods in the same case, but because you were concerned about the pain, so you wanted something acute, and the left side was not painful, so they're fine with that.
Nice.
So hopefully I'm not behind with the time. Open for any questions, and I think I've done.
Yes,
Yeah,
thank you so much, sir. I think we have 3 questions. The first question from Dr. Yasser, what intraoperative you look for to do which osteotomy?
So I kind of answered this question, Dr. Yasser. So it's intraoperative people would do flexion to see if there is more anterior deficiencies, so you can get anterior coverage. And Dr. Salter said you don't have to do this because usually for DDH you need anterior coverage. Usually for CP you need posterior coverage. So you can do the intraoperative test. I like if you have the plan pre-operative, it doesn't change too much. And especially when I do DEGA now for all my cases, I just change the plan is either to do the graft, the bigger graft, mostly anterior or mostly posterior. Can I put the graft without separation in shelf osteotomy to avoid bone necrosis? Without separation. You mean from the outer table and flip it down? That's a way, that's a Stahili way. But yeah, I think I understand the question well, Dr. Mohammed. All right.
I think we have no more questions, sir.
Perfect. Thank you.
Thank you so much for being with us, Dr. وليد, وكل عام وحضرتك بألف خير يا فندم.
كل عام وحضرتك بخير.
ربنا يخليك يا فندم. Thank you so much, sir. Our next speaker will be, I think we have one more question. How to treat short neck after treatment of DDH?
So if the patient between the age of 8 and above and have short neck, make sure you do another assessment that's not due to AVN or growth abnormality. And if it's wide neck, short neck, GT overgrowth, the Morser osteotomy would be the best option. It's actually neck lengthening osteotomy and also help you to get the GT down and get some tensioning of the abductors. It's actually important to get the offset of the neck so can maintain the stability. I had another case similar to what we had the discussion with Dr. Bahat now. She had a very short neck and also significant anteversion. So it's interesting. You get one X-ray, it looks like she's subluxed. You get another X-ray, looks like it's in. Then we decided to derotation osteotomy plus Morser at the same time, so we can get the offset tensioning and also we can get the version and the correct side, and she's doing very well.
Thank you so much, sir.
Thank you, sir.
Thank you, sir, for being with us. يعني احنا دايما حضرتك معانا كده يا دكتور وليد، ودايما عامل لنا سبورت قوي في كل الساينتفك اكتيفيتي في مصر. يعني ربنا يبارك فيك يا فندم.
That's my pleasure. That's my
Thank you so much, sir. Our next speaker will be Professor Ahmed Khamis from Egypt, Dana University. Professor Ahmed will speak about open pelvic fractures. Professor Ahmed, thank you so much for being with us.
Thank you, Dr. Muhammad. I'm very pleased to be with you today. Actually, my talk will be about, can you see my screen now?
Not yet.
Okay.
You opened it, Dr. Ahmed?
Well, now you can see it?
Not yet. You pressed on sharing the sharing button?
Yeah. Okay. Now?
No, not yet.
Just a second. I think now is okay.
Yes, yes. Starting, yes.
Sorry for this
Yes.
delay. Thank you very much,
No,
Dr. Muhammad,
not
for kind invitation.
Not a problem, sir.
Thank you.
Please slideshow. Please slideshow, Dr. Ahmed.
Yes, it's okay now. Okay,
Yes.
my
you so
presentation will be about open pelvic fractures. This kind of pelvic fractures has a very, very high mortality rate, and in not a few cases, this injury could be missed. What about the epidemiology of the open pelvic fractures? Of course, it's due to high energy trauma. So we should suspect many concomitant injuries in this polytrauma patient. The incidence is low. It's a rare injury. It's about 2 to 4% of pelvic fractures, and more force is required in a child to obtain an open pelvic fracture because their tissues and bones are more flexible, so they can withstand high degrees of force before they fractured. And evenly, they have 3 to 4 times more incidence of open pelvic fractures. This is something somewhat more dangerous. The fracture hematoma communicates, of course, with the external environment, but this is not usually through a wound. It could be through an internal organ, and the danger comes from this communication through a rectal tear, vaginal tear, or perineal tear. This area is extremely contaminated, and the risk of infection is very high. Massive hemorrhage, together with the bleeding from the pelvic fracture itself, may cause early exsanguination of the patient due to loss of pelvic tamponade and any associated vascular injuries. Mortality due to open pelvic fracture occurs late. Mortality early from pelvic fracture occurs from hemodynamic instability. Late mortality from open pelvic fractures occurs from sepsis. It's a massive intrapelvic sepsis. And of course, from also multiple organ failures due to this sepsis. Early fecal and urinary diversion is a must. Repeated aggressive debridement of the wound, pre-sacral wound drainage, and vac drains decrease risk of death from sepsis. The mortality rates changed with the change of the care of pelvic fractures through the previous decades. In the 70s, mortality reached up to 50% of the cases. From 90s to 2000s, the decrease in the injury severity score due to better management regimens, it decreased to about 48, and the mortality decreased to 14%. This is much less than 50% in a study by Lennon et al. In 1993. But other studies like that by Grotz et al. And Ferreira et al., Davidson et al., they showed different rates of mortality. This all due to the aggressive trauma protocols. And this change in the rate of mortality could be attributed to the articles published Most of them are case reports, and nothing have been published till now about a big number of cases with open pelvic fractures. In 2020, mortality reported to be 21% and 23% in another studies. Why it varies? As I said, it's because of massive blood loss, infection, sepsis, and any other associated head injuries. These are all contributing to the differences in mortality. So it's not only one factor, it could be multiple factors. The injury severity score is related to mortality, and it had been reported that injury severity score of 26 is a profound injury, and injury severity score more than 35 will be associated with more deaths. Do we have a classification of the open pelvic fractures different from the Gastello-Anderson classification for any long bone fractures? Yes. Faringer et al. In 1994 divided pelvic fractures into 3 zones. This classification is actually regional classification. So he divided the open pelvic fractures according to the area of injury. Zone 1 in the perineum, which is very medial zone, the perineum in the area of the pubis or the medial buttock or the sacrum. It's the very midline area of the pelvis. In this zone, fecal diversion is a must and washout is extremely necessary. In zone 2, it is more lateral than zone 1. It's in the groin and the medial thigh. Zone 3 is posterolateral in the buttocks as shown in this figure, and the iliac crest shown in this figure by the blue area. Furthermore, Lee and Wang in 2019, they studied how much mortality occurred in relation to these anatomic zones. They found that in area 1 perineal region, the mortality rate is 20.7%. And they have 86% of bladder or urethral injury and 51% of anorectal injury. In zone 2, the ilioinguinal zone, the mortality rate increased to 45%, and 90% of these patients died from vascular injury. In zone 3, the sacroiliac zone, 71.4 mortality rate, and all patients have vascular injury. 28.5% they have anorectal injury. So in zone 3, according to Li Wang, this is extremely dangerous and the mortality rate is extremely high. Now, these photos show some examples of these cases in type 1. This area is the perineal injury in the uppermost photo. The second one is in the ilioinguinal region in the type 2 injury. And these all photos show how severity is the injury and how much we should suspect of the presence of associated lethal injuries in the anorectal region or in the vascular structures. So now I have to define what are the principles I must follow in management of these patients. Number one, and first of all, we must work in team. It's a multidisciplinary approach, not only the orthopedic surgeon. We must inform, and I think it should be immediately to inform the urologist, the general surgeon, and the OB-GYN. Once the patient arrived to the emergency room and we have the signs to suspect that he has an open pelvic fracture. Of course, we should go through the advanced trauma life support protocol with aggressive resuscitation to prevent exsanguination of the patient from hemorrhage. Tranexamic acid administration early in those patients can decrease the bleeding markedly. Immediately, we should give antibiotics and tetanus prophylaxis. And if this could be possible at the scene of injury, the results will be much better. Then this is followed by temporary pelvic stabilization, damage control orthopedics, pelvic binder, the C-clamp, anterior external fixation. We must stabilize the pelvis temporarily to prevent further bleeding. Once the patient is hemodynamically stable, we should address the anorectal and vaginal injury first. Then the urologic injury. Anorectal or vaginal injuries have much higher rates of infection. Then this is followed by definitive pelvic stabilization. Debridement should be repeated if needed to avoid the progress of infection and sepsis, and of course to avoid mortality. Later on, the urogenital complications of injury will be addressed through the specialized consultants. If we are going to talk about the urologic injuries in some further details, the incidence in open pelvic fractures is about 10 to 15%. Military explosive injuries cause complex injury 3 times more than the civilians. This classification is the Goldman classification of urethral injury. He divides the urethral injury with pelvic fractures according to the site of the injury. In type 1, this is the rupture of the puboprostatic ligaments and surrounding periprostatic hematoma. It caused stretching of the urethra without rupture. In type 2, it's a partial or complete injury of the membranous urethra above the urogenital diaphragm. In type 3, it's the same as type 2, but the injury is at the level of the urogenital diaphragm. In type 4, the injury extends to the bladder neck. And in type 5, it's injury of the anterior part of the bulbous urethra. In urethral injury, they can be delayed, repaired in a delayed fashion. The clinical picture that we should suspect the patient has a urethral injury. Number 1 is blood at the external urethral meatus and high riding prostate on PR examination, or if the patient has a perineal or scrotal hematoma, and if he has a urine retention. The volume of urine is extremely important, so we need to assess this even for the resuscitative efforts of the patient regarding his hemodynamic instability if it's present. Scrotal or labial swelling means there is anterior bleeder inside the pelvis, and this needs surgery. A retrograde urethrogram is important if we suspect a urethral injury. This is of course done by the urologist, and they are seeking for contrast interruption or extravasation in the pelvis. In the picture on the left lower side of the screen, we can see the interruption, complete interruption of the contrast. And in the picture on the rightmost of the screen, we can see extravasation of the contrast inside the pelvis, which might mean there is a partial injury of the urethra. In the uppermost photo, this is the site most commonly injury of the urethra happens, and it's in the membranous urethra. This is a cystography. It's not an assisting urethrogram, it's a cystogram, and it shows a complete dissociation. The contrast doesn't go through down the urethra, and it stopped at the level of the membranous urethra just below the prostate. Number 2 is the bladder injuries. As I said, the cystography and CT contrast cystography is important if we suspect these cases. It will show there is intraperitoneal or extraperitoneal type of ruptures, and the management, of course, will differ. In extraperitoneal bladder rupture, we can see the contrast surrounding the bladder from outside and in the retropubic area, which is called molar tooth sign. It looks like a molar tooth inside the pelvis, a big one, and this is the extravasated contrast. This is a simple extraperitoneal bladder rupture. The contrast, which looks in blue color, will surround the bladder in the perivesical space. But in case of intraperitoneal bladder rupture, the CT cystography will show extravasation of the contrast around the bowel loops in intraperitoneal space. In those cases with suspected or diagnosed bladder injuries, a Foley's suprapubic catheter must be inserted. This should be tunneled to prevent anterior contamination of the wound if we are going to fix the anterior pelvic ring. Regarding the management of the urologic injuries with open pelvic fractures, we have to note that patients or motorcyclists came with pelvic fracture, they have very, very high incidence of bladder and urethral injuries, up to 80 to 90% of cases. For a bladder injury, the pelvic fracture, and if we have a pelvic fracture and hematuria, we should suspect 30% of cases having a bladder injury. Here, the retrograde cystography is a must. If there is a suspected bladder rupture from the clinical picture, the patient will have oliguria, distension of the abdomen, inability to urinate, suprapubic pain, and widening of the symphysis pubis or the obturator ring displacement more than 1 centimeter are highly suspicious of the presence of a bladder rupture. The management depends on the anatomical location of the injury, intraperitoneal or extraperitoneal, and also about the associated injuries. If there is intraperitoneal or complicated extraperitoneal injuries with a fracture or associated vaginal or rectal lacerations, those need immediate surgical repair together with the management of the associated injuries according to the protocol mentioned before. For extraperitoneal injury, which is uncomplicated, this patient needs prolonged drainage by a suprapubic Foley's catheter and surgical repair in those patients undergoing open reduction internal fixation, in the same time to minimize the postoperative infection. This must be done in cooperation with the urology team. The management of urethral injuries, if suspected, as we said, blood at the urethral meatus, we should avoid inserting a Foley catheter through the urethra. And a retrograde ureterogram must be done to assess if this injury is partial or complete. Then a suprapubic catheter is inserted. Why we must insert the catheter? Because we must assess the volume of blood for resuscitation in the shocked cases. There is no current evidence that a suprapubic catheter will increase the rate of infection after open reduction internal fixation of symphysial injury. If there is associated injuries to the kidneys, ureters, testes, ovaries, or uterus, those are all possible, and they must be evaluated by the urologist and the OB/GYN consultants. The other type of injuries that cause open pelvic fractures from inside is the vaginal injury. Also, the vaginal injury is rare, about 4%. From these persons, 72% of them are in tile type B fractures, 28% of them are in tile C fractures, with no difference in severity of the injury between the two types. Symphysis disruption or pubic ramus fracture or a vertical shear fracture means higher severity because the bone might penetrate the vagina and recoil back. If you have a look at the X-ray in the upper right side of the slide, this patient has bilateral fracture of the pubic rami and a posterior sacral fracture. And this degree of displacement is very minimal, so we could suspect it's an innocent fracture. However, this was not an innocent fracture, and a piece of the pubic ramus during the moment of injury penetrated the vagina and caused this vaginal tear with the arrow pointing on it. With the elastic recoil of tissues, the fracture is somewhat reduced to its original position, and the X-ray might be misleading. Those injured might be missed because of the trauma stress might cause vaginal smooth muscles contraction, and this will reduce the degree of vaginal bleeding. PV and PR examinations are must, and I think they should be done in all patients, even if there is no bleeding. All patients with pelvic fractures, even if there is no bleeding from the vagina or from the rectum, because the bleeding might be less than expected to be due to an open fracture extending into the vagina or rectum. We have a classification of the vaginal injury according to the amount of, according to the depth of the wound in the vaginal wall. In the first degree, it's a contusion or hematoma or a superficial mucosal laceration. In the second degree, the injury extends to the submucosal fat or causing a muscle laceration. In the third degree, the laceration extends into the cervix, the peritoneum, or even into adjacent organs. What about the treatment of the vaginal injury? Of course, everything should be done after resuscitation of the patient regarding stability of the hemodynamic state and temporary pelvic or primary pelvic stabilization. The gynecologist should manage according to the degree of the vaginal injury. For the first degree, packing with gauze is enough. Second and third degrees need repair. Repair will be interrupted absorbable sutures. If there is a fracture of the pubic ramus that penetrates the vaginal wall, and this could not be reduced to its original position, it must be excised through the vaginal tear itself before repair of the tear. By recreation of the hemipelvis internal rotation that caused the penetration of the vagina, then reduce everything back by external rotation on both anterior superior iliac spines and the thighs to obtain anatomic reduction of the bone. Local antibiotics are extremely important to be put in the pelvic dead space. Vancomycin, topramycin, cement beads, and covered with a metronidazole for the vaginal flora markedly reduce infection rate as in the picture showed. The complications of the vaginal injury, of course, infection comes on the uppermost complication. It needs debridement, repeated, and dressing, incision and drainage if any abscess is collected. Vaginal stenosis and sexual dysfunction are late complications. Infection and sepsis after genitourinary injury is not uncommon. The mortality risk now shifts from the hemodynamic instability to wound infection and sepsis. For open pelvic fracture with a vaginal injury, there is 25% of infection. Early systemic broad-spectrum antibiotics covering both gram-positive and gram-negative fractures are important, especially for those injuries, Gastello 3, and these decrease significantly the rate of infection. Local antibiotics, as shown in the previous slide, for the cement beads inside the pelvic wound decrease infection. And some argument presents about later removal of the cement beads because they continue to elude antibiotics for months, but after this, they might act as a nidus for bacterial colonization. Topical vancomycin and topramycin powder also are good to decrease the rate of infection after open reduction internal fixation. In case of vaginal lacerations, the vagina contains many aerobic and anaerobic species, but lactobacilli is the predominant. So there is limited evidence on a proper antibiotic, but in general, the second generation cephalosporin for third and fourth degrees perineal tears, together with metronidazole for the anaerobics, are recommended. The next injury is the rectal injury. It's more rare than a vaginal or urethral or bladder injury. It's about 1 to 2% of the fractures, and if missed, it will cause severe sepsis. It is suspected on the presence of a gross blood on the digital rectal examination, but this is not always present. So I think it's much better to have a PR for the patient in peace, just to be sure that there is no blood inside the rectum. Bowel entrapment also is another type of injury that can occur with a pelvic fracture. This is rarely reported, but potentially fatal. Diagnosis is often delayed, and because it's difficult to differentiate entrapment from adynamic ileus or paralytic ileus. CT scan with a contrast is important, or even without a contrast, we are looking for a multifocal air densities and hematomas around the rectum as shown in this cut of CT. We can suspect the presence of this injury if there is a symphyseal widening. It's a sensitive indicator for rectal or lower urinary tract injury. In severe symphyseal widening, there might be 75% suspicion of rectal injury, 72% suspicion of bladder injury, and 85% suspicion of urethral injury with severe anteroposterior compression mechanism of injury. Rectal injury at any intra-abdominal organ, it might be intraperitoneal, and this is managed as a colonic injury, or extraperitoneal, and this needs colostomy, distal rectal washout, presacral drainage, and rectal repair. But the treatment varies in many reports. Johnson and Steele, 2013, they recommended proximal diversion, and direct repair of the rectum is unnecessary. Boserg recommended that presacral drains as a routine measure should be avoided, and distal rectal washout also. Guac et al., they said that extraperitoneal injury should be managed with stoma, colostomy, regardless of the primary repair. So the main point now is that we must have, or this patient must have, diversion of the stool from this area by colostomy, whatever is going to have a primary repair, presacral drainage, distal rectal washout, and colostomy is the most important measure. What about the patients if they have combined rectal and bladder or urethral injury? This is more severe and more dangerous condition. This is also rare, 3 to 5% of pelvic fractures. The cause is that either a longitudinal tear of the bladder neck, the prostatic or the proximal urethra, this tear extends into the rectum. The other cause might be a simultaneous injury of the posterior urethra and the rectal wall. The immediate goal by the urologist is to prevent pelvic sepsis and subsequent osteomyelitis by establishing urinary continence and or proximal urinary diversion. The management, also there are few clinical reports now available about this critical topic. It must be an emergency within the 21st hours from the injury. There might be primary repair of all injuries, suprapubic cystostomy, and delayed repair of the injuries, or to approximate the bladder neck laceration and to put a catheter realignment of the urethra. The urethral catheter balloon, if left in situ at the time of urethral repair, may produce tension on the already compromised bladder neck, and this might cause dehiscence of the repair. So urethral stents or nephrostomy tubes are important. Again, the main idea is to divert the urine away from the site of the repair, the same regimen as diverting the stool away from the site of repair of rectal injury. Regarding rectal injuries in this combined injury, distal rectal and pelvic washout, pelvic drain, primary rectal repair, and colostomy are the mainstay of treatment. What about the outcome of these injuries? Hassman et al. In 2020, they put a review on 18 cases with this type of injury. They found that 72% of the patient could not get rid of the colostomy, and they needed permanent colostomy. This was based on the extent of rectal injury, and this was due to the continuous fecal continence or rectal sphincter denervation, fecal incontinence or rectal sphincter denervation secondary to injury to the sacral nerves. This simplified algorithm of the management after the initial assessment and stabilization of the patient, we should define if there is a bladder neck laceration or no bladder neck laceration, repair or ligation. If there is presence of any neurologic injury, the outcome will be affected. And again, the urologic injuries, if they are isolated, they can be repaired in a delayed fashion. If the patient has associated rectal injury, this is an emergency, and the anorectal injury must be addressed first. Finally, in conclusions, number one, in compound pelvic fractures, the initial goal is not the wound itself, it's the prevention of exsanguination of the patient if he's shocked with aggressive intravenous fluids, blood products, clotting factors, pressure dressings, and even embolization of bleeding vessels. Then the temporary pelvic stabilization. Once the patient is hemodynamically stable, those patients with transmural rectal or anal lacerations will undergo distal rectal washout and proximal diverting colostomy or ileostomy, followed by thorough debridement of non-viable tissues and primary rectal repair, if possible, by the general surgeons. Then there will be the surgical treatment of the urogenital injuries. Placement of pelvic drains, stabilization of the pelvic fracture is important by external or combined techniques of external and internal fixation. And finally, wound vacuum placement. We should not close this dirty wound primarily, but vac drains will do good work in these cases. Open pelvic fractures have high mortality rate, of course, due to infection. This will be delayed mortality, and the early mortality will be from the associated vascular injuries if possible. The patients need frequent returns to operating room for repeated wound debridement and irrigation, removal of dead tissues in the post-traumatic period. Due to patients' labile clinical course, urologic injuries can be addressed in a delayed fashion if his condition is allowing us to do this. Typically, in the 5th post-operative post-injury day, and this will be by the urologist. The last thing I would like to say is it's not a one-man show, it's a teamwork, multidisciplinary approach, and I do recommend that we should inform the urology, the general surgery, and the OB/GYN if we have a patient with a suspected open pelvic fracture arrived at the emergency. Thank you very much.
Thank you so much, Professor Ahmed Khamis, for this very interesting talk about a very important topic that, if not properly managed, I think it will be fatal. So I have a question from Dr. Gamal Qasim, which is a very important question. What is the rate of success for these very difficult, complicated emergency injuries?
Well, the rate of success, we don't have fixed numbers, and in the published data till now, we don't have a fixed number of success rate, and the outcome depends on many, many factors. Actually, number one, first of all, is the hemodynamic state of the patient. Number two, what the severity of injury of those associated soft tissues, anorectal, vaginal, or any other intra-abdominal injury. Those patients are polytraumatized patients. They might die from a brain injury. They might die from chest injury. We can say that we have a fixed rate, and I cannot say this, of success of those patients, but we are doing our best efforts to control, number one, shock of the patient, number two, the suspected later on infection. Of course, we have late complications of those injuries regarding the rectum. This patient might have fecal incontinence for the rest of his life according to his severity of injury. And in female patients, they have some vaginal issues, vaginal stenosis, difficulty in sexual function, the urology, they might have incontinence of urine, stricture of the urethra, and any other associated injury. These are not fixed numbers.
Yes.
But it's low. I cannot say it's high. It's a high success rate, but it's not like the common fractures.
Yes. Dr. Ahmed, have you been faced with combined urorectal injuries?
Well, in few cases, this is not a common injury. In just a few cases, we have reported something like this. But all these patients were managed by the general surgery, of course. Actually, we are facing more of the incidence of the urologic injuries regarding the urethral injuries or bladder injuries. And sometimes we fix the symphysis pubis, and for the later approach of the urologist to repair the urological injury, they asked us again for removal of the plates of the anterior pelvis because of their approach might be from the suprapubic region or even from the perineum itself.
Yes, Dr. Ahmed, you have already answered the next question from Dr. Yaqub. Can we do internal fixation with anterior pelvic ring at the same time with both intraperitoneal and extraperitoneal bladder injuries?
Well, for extraperitoneal, we can do safely the internal fixation, but for intraperitoneal, this must be a multidisciplinary decision. I cannot take this decision as an orthopedic surgeon alone. There must be a deep discussion with the urologist, and if we need a general surgeon, everyone should put his advantages and disadvantages of his technique. And for anterior pelvic injury, I can put an external fixator. This will be safe for everyone. I will not be in a worry about this case, and even them will not be in worry. The frame will be away from their approach, and the patient will be safe and stabilized. If the anterior fixator can be used as a definitive treatment, this will be much more good for everyone. If I need internal fixation, I have about 3 weeks from the injury to put a plate anterior or something if needed like this.
Yes.
Thank
you so much.
Thank you for your.
Dr. Baha, please.
Yeah. We have some problem now. We're facing that. What you about the urethral injury, about the technique of chemin de fer or direct repair? Which one you always prefer?
Me, myself, I'm not taking the decision of repair of a urethral injury. This is a decision of the urologist. But it depends on their degree and their assessment of the injury. From my point of view and from the cases I have seen before in the previous years, they do prefer the delayed repair. They put a suprapubic catheter and they say that everything should be calmed down and the pelvis is stabilized, then they will go for the delayed repair. I think they prefer the delayed repair, but with a time frame, because they do not like to have a urethral stricture or stenosis that could jeopardize their decision and the surgical technique later on.
Okay, thank you.
Thank you so much, my dear friend and my dear brother, Dr. Ahmed Khamis, Professor Ahmed Khamis, for being with us. شكرا جزيلا دكتور أحمد. شكرين حبيبي. Thank you so much. Thank you so much. Our next speaker will be Professor Mahmoud Badran from Asyut University, Egypt. Professor Mahmoud will speak about a very important topic, which is the decision-making of acetabular fractures, indications, and timing. Professor Mahmoud, please, sir.
Thank you very much, Professor Muhammad Al-Ashab, and many thanks also for the Egyptian Orthopedic Association for organizing this wonderful event. Till now, I'm happy to be among those eminent faculty from India, from Canada, and from Egypt, of course, from most of the universities. For those who don't know me, my name is Mahmoud Badram. I'm an assistant professor for orthopedic surgery and traumatology at Asyut University Hospital. I would like at the beginning of my presentation to acknowledge the role of Professor Mark Riley from USA and Professor Osama Farouk from Asyut University for providing some of the interesting cases in doing my presentation. So regarding my conflict of interest, I have no conflicts of interest to declare. So the objectives of my presentations are going to focus on three main things. First, to define the factors affecting the decision-making process for management of acetabular fractures, and then we are going to list together the indications of operative and non-operative treatment, as well as we are going to have a focus on the role of timing as a factor that may affect the outcome. When you look to the decision-making in acetabular fractures, you are going to find that there are multiple factors affecting the decision-making. We have some factors related to the patient himself, whether the general condition of the patient is okay, the age of the patient, what about his bone quality, neurological examination, as well as the most important thing, which is the skin and soft tissue condition. And also, we need to assess the fracture itself. We need to know the classification, the roof involvement, the articular involvement, the stability, and the congruity. But we need to understand one of the most important things. This is a golden statement said by Emile Letournel himself. Treatment should not be commenced until a full understanding of the fracture is achieved. So the first thing that can help us in the decision-making of the treatment of acetabular fractures is to understand first the classification of the acetabular fracture. And this is almost a basic knowledge, but we need to stress again on it, that the acetabulum is composed of a cavity that's present inside the columns of the acetabulum, the anterior column and the posterior column. And based on the fractures, we have two different types of fractures. We have either the elementary fractures, which we involve only single fracture line that may involve either the posterior column, the posterior wall, the anterior column, or the anterior wall, or of course the transverse fracture. And also we have the associated fracture types where we have at least two elementary types are present here. Like what? Like the transversus posterior wall, the TOS posterior wall, associated both column, anterior column, posterior transverse, and the posterior column and posterior wall fractures. So first, we have to understand the classification of our fractures. Then we have to understand what's meant by the roof. So the roof is representing the superior weight-bearing area of the acetabulum. And in order to understand this roof, we need to know that the roof is not only a 2D dimension, but it is a 3D. So we need to measure this roof arc and superiorly, anteriorly, posteriorly, and of course medially. That's why we have the roof arc measurement developed by Matta, which represent the area of the intact part of the acetabulum just above the femoral head. So if this intact area is away from the femoral head, we may go to conservatively treat acetabular fractures, but this is only in transverse fractures. So one of the most important things that can help us in the decision making is to understand that the roof arc measurement, when we are measuring it, we are not measuring it for any fracture except for the transverse fracture only. And in order to measure this roof arc angle, we need to know that we need to measure it in all of the three views of the acetabulum. We have the AP, we have the obturator oblique, and as well as we have the iliac oblique view. And here is the fracture line. So the center of the hip is here. This is the vertical line extending from the center of the hip. And then we are going to measure the angle in three different views. And then we are going to add the summation of these angles, dividing them by 3 to get the roof arc measurement. So if this roof arc measurement is more than 45 degrees, we can go with non-operative treatment, could be considered, but we are going to give you more details information about this. But you need to know that measurement of the roof arc measurement is not to be used for any other fracture except for the transverse fracture of the acetabulum. The third thing, we need to understand what we meant by articular involvement. And we have here 3 kinds of displacement that can affect the acetabulum. Either we have the step off, or we have the gap displacement, or we have the impaction injury of the acetabulum. When you look to this paper published in JBJ American in 2018, it's speaking about the predictors of the best outcome that can happen after acetabular fractures. You will know from this study is that acetabulum can tolerate gap displacement if it is less than 5 millimeter, rather than to tolerate any step displacement more than 1 millimeter. So, based on this, conservative treatment could be applied if we have a step less than 1 millimeter, if we have a gap less than 5 millimeter, but better than those of all is that anatomical reduction has to be achieved if you are going to do surgery for this fracture. The fourth thing, we need to understand what we meant by hip joint stability. And we mean here the location of the femoral head in relation to the acetabulum. What we mean by dislocation of the femoral head, which is common to happen, especially with posterior wall fractures. And it may, most commonly of the femoral head dislocation are happening posteriorly, but you need to know that the time to relocation of the femoral head is very important because it may increase the incidence of development of AVN and to have poorest outcome in doing your acetabular fracture. So if we have an acetabular fracture that's associated with a dislocation, please don't go to do CT scan unless you have done urgent reduction of the hip. However, it has to be done as early as possible. It has to be done in a traumatic way, and you have to avoid multiple attempts. Why? Because sometimes you may have some incarcerated fragments present inside the femoral head that can prevent you from doing your reduction. So when you look to this paper again, the predictors of post-operative outcome, you are going to find that the poor prognostic factors are associated if we have initial fracture displacement of more than 20 millimeter, or if we have a joint dislocation. So we need to do urgent reduction of those joints. What about the rule of traction? Do we have any rule of traction? Yes. The answer is yes, because we have some concerns of mechanical wear, some concerns regarding the persistent hip subluxation, hip instability. You may find some incarcerated fragments. That's why I told you that you need to do traction of the femoral head after doing the urgent reduction in order to avoid any damage to the cartilage itself inside the acetabulum. So if we have step displacement less than 1 millimeter, if we have a gap displacement more than 5 millimeter, we can go for conservative treatment. But can we apply this for all kinds of fractures? Well, we are going to see. We have this displaced large posterior wall fracture here, okay? But when you look to this displacement, no, it is displaced because the posterior wall position was not here. It was here. So it is displaced more than the 1 or 2 millimeters. So we are going to go with open reduction internal fixation of such kind of fracture. But sometimes we have a posterior wall fractures that are undisplaced and may involve less than 20% of the posterior wall. So the fracture line could be like here, okay? And it may represent less than 20% of this one. Can we consider this as an indication for doing conservative treatment? Well, we have to measure first. We have the ability to do CT scan, and this CT scan have to have the cotyloid fossa. We need to have the cut where the cotyloid fossa is here. Then we measure this whole length, and then we measure the length of the fracture, and we divide them, and we see if it is less than 20% of the posterior wall. We can go with conservative treatment because most of the fractures are considered stable. However, if we have posterior wall fractures that are a little bit higher than this area or involving more than 20%, we are considering this as unstable fractures, and we have to go with internal fixation. But what about this 20%? Is it really important? Well, when you look to the literature, when you look even to your experience, you are going to find that we have to estimate if it really affects the stability of the hip or not. That's why it's very important for you, if you are going to do conservative treatment or operative treatment, is to test first under fluoroscopy the stability of the hip after doing your after doing the CT scan. You need to test the stability because sometimes you may find instability that are affecting the stability of the hip joint, and hence you are going to do surgical management. So for example, we have here this fracture of the posterior wall, and once we have done stress test under anesthesia, we have found that the hip has been dislocated again posteriorly. But you may think that, no, we have a large fragment. So let's look to this fracture. We have this small fragment as evident here, okay? And when we have done the stress test, we have found that, no, it is a little bit dislocated when you subluxed when you compare the distance between the femoral head and the floor of the acetabular. Are going to find that it has opened a little bit. This means that this fracture could be dislocatable, and we need to do open reduction internal fixation of fracture. So for posterior fractures, if it is undisplaced, less than 20% affection after doing stress test under general anesthesia, and we have found it stable, we can go with conservative treatment. Otherwise, I urge all of you to do open reduction and internal fixation for this posterior fracture. What about the cartilage injuries? We have spoken about the step and gap, but we need to know the outcome. The worst outcome can happen with anatomical reduction if we have seen a subchondral impaction or intra-articular fracture fragments, and we were not unable to extract this fragment or to reduce this impaction. So it's very important when you look to the X-ray or look to the imaging of the fracture acetabulum to define if we have an impaction or not, because even if we have undisplaced fracture, once we have found impaction, it's important to do a relocation of this impaction and do internal fixation of the fracture. So when you look to this fracture here, when you look to the trauma is on the left side here, okay? But when you look for the first time, we may think that I don't think that we have any problem here. But when we look closer, when you look to this distance and you compare it to this distance, actually on the left side it's wider. This means that we have something. We may have something. So please do not underestimate any fracture regarding the hip region. You have to do CT scan because sometimes you may find an area of impaction of encapsulated fragment present here, and in this time we need to extract this fragment and do definitive internal fixation by doing spring plate if we have a small fragments of the posterior wall. What about the hip joint congruity? We need also to understand what's meant by congruity. Congruity means a relationship between the femoral head and the rest of the intact part of the acetabulum. How to judge this congruity? Sometimes you may have a fracture like this. This is minimally displaced transverse fracture. But when we looked closer to the lines representing the roof of the acetabulum, which is still the intact part, and the femoral head, we're going to find that those two lines are not parallel. So this means that if we have a fracture undisplaced with minimal step or minimal gap that can go for conservative, and we have found that the femoral head is incongruent with the roof, this means that it's urgency to do open reduction and terminal fixation of this fracture because we have incongruent hip. And this understanding the concept of congruency will give us another idea about the secondary congruency. The secondary congruency, it is an extra anatomical orientation of all articular fragments around the femoral head. I need to tell you that it has understanding this concept has to be used with caution because it has multiple conditions. First, it shouldn't be used unless we have associated both column acetabulum fracture. So this is condition number one. And condition number two is that we may use it as an excuse for doing conservative treatment in elderly patient, especially if we have other comorbidities that may affect the outcome, and understanding that these fractures might end with arthritis at the end. So it can be used as an excuse only if we have an associated both column acetabulum fracture and only in elderly patients. But if we have an associated both column like this, don't go for conservative treatment, of course, because we have incongruency, displacement of the acetabulum fracture, and we have to go with application of modified stop approach or a plus lateral window to reconstruct the whole acetabulum. When you look to the literature to see what other papers saying to you about the understanding of the concept of secondary congruency, actually it works. But again, when you look in the deep in the literature, the papers, you are going to find that in selected indications of associated both column, as I told you, and in elderly patients. So when after understanding of all of those concepts, you are going to know now that most of acetabular fractures will require operative treatment. So in order not to give you the indications of operative treatment, no, acetabular fracture, operative treatment, unless we have one of those indications. And those indications have been spoken about already. Well, if we have a posterior wall fracture that involvement of less than 20% on the axial cut, where we have the cotyloid fossa, we measure the surface of the affected fragment, and if it is less than 20%, and then we have done stress test under general anesthesia, and we found no instability happens, we can go with conservative treatment. And if we have a both column fracture with secondary congruency in elderly, but we have to do it with X-ray out of traction. Don't do traction to the limb and say that this is a secondary congruency. No, it has to be done if we have an X-ray out of traction, or if we have a transverse fracture of the acetabulum where the roof arc measurement is more than 45 degrees, or if we have other fractures that are non-displaced with less than 1 to 2 millimeters of displacement, regardless of their location. And after understanding the indications of operative and conservative treatment, let's look now for the operative, the aim of operative management. The aim of operative management, without going into any details, you have to achieve anatomical reduction of all fracture. Okay, you have to avoid step displacement. Even by, if you find a step displacement of 1 millimeter, you may find the worst outcome. So avoid step displacement. You have to relocate the dislocated hip urgently, as urgently as possible. You have to reduce any impacted fragment. You have to select the proper approach. I'm not going to speak about the approach because my colleague, Dr. Saad Shula, is going to speak about this. And you may consider minimal surgical approaches. But you may think that, oh, we know that minimal invasive techniques could be applied in pelvis fractures. But can we apply it in the acetabulum fracture? Well, the answer is yes, but it has also very selective indications. If we have a minimally displaced fractures, potentially unstable acetabulum fracture, we can apply minimally invasive technique, especially if we have a gap of less than 5 millimeters, because as you know that the gap is best to be closed by a leg screw, where we can apply it in minimally invasive way. Or if we have a fracture displacement with a gap, with we can use a leg screw, as I told you, or if we have a slightly displaced high anterior column fracture, or if we have displaced fracture and we have achieved anatomical reduction either using closed method or mini open methods. So closed reduction has to be achieved first. If you are going to apply minimally invasive techniques, you can apply hip manipulation, you can do manual traction of the injured limb, you can apply Shan's pin as you see here in the anterior inferior spine, and then you can use it as a joystick technique in order to reduce this fracture. So if you applied a reduction and the fracture has been reduced anatomically in front of you, as here we have in this case, 26 years old patient, transverse fracture acetabulum with fracture pelvis, sacroiliac dislocation. We have posterior column, retrograde anterior column, and 2 iliosacral screws have been applied, as you see in all views of the pelvis and the acetabulum. But if you fail to achieve closed reduction, sometimes you may have an excuse to do some mini open approaches. Okay, like this approach, we have published it in the injury journal in 2014 by our team from Massachusetts University. It has increased the indications of minimally invasive techniques to include more displaced acetabulum fractures, but only again in anterior displaced acetabulum fractures, where we can use this small incisions to apply the impact to derotate or to compress against the fracture fragment until the fracture is reduced, and then we can apply the leg screws. Actually, also you can use this approach to apply small plates through this approach. As you see here, this is the skin incision, and we have applied small plates that acts as a spring plate to hold the quadrilateral plate. It can increase the indication of the minimally invasive techniques. However, you have to know that anatomical reduction has to be achieved in every way, either using closed method, mini open method, or open reduction method. What about the timing of surgical approaches? The timing is of utmost importance. However, you have to know that we have criteria to be filled. Unless we have well-resuscitated patient, proper radiological workup, proper understanding for a fracture, and proper operative team to manage those kinds of fractures. However, you need to know that sometimes we have some surgical emergencies regarding the acetabulum, although they are rare, but it's important to know them. If we have a sciatic nerve palsy that happened immediately after closed reduction of your fracture hip dislocation, this is an urgency to do open reduction and to look what happened to the sciatic nerve. If you have an irreducible posterior fracture hip dislocation, or if you have, which is very, very rare, the open acetabular fracture, or if we have vascular injuries that can happen with the acetabular fracture. So is it really important to have the proper timing? Yes. As it's important for the pelvis, it's again important for the acetabulum. When you look to this paper in Journal for Orthopedic Trauma in 2016, they have performed, should be performed as early as possible, and the anatomical reduction has to be achieved as early as possible for most kinds of fractures if we have applied it in an early time. Again, this paper, meta-analysis by Peter Gianodis, speaking about the importance of having the proper timing for doing maximum accurate reduction with minimal surgical approaches. And when you look to the outcome of reduction achieved, if you are doing your anatomical reduction within the first week, we're going to find that some papers are speaking about the quality of reduction could be achieved in 74%. But as you go in time, you are going to find that the quality of reduction will decrease by going in time. So, do we have an optimum period for our fractures? Yes. For complex associated fractures, the best outcome are going to happen for you if you have applied open reduction internal fixation in the first 5 days. This is according to most of the literature and those two important papers I have spoken about. And if you have simple fractures, this period can extend to go to 15 days after the injury. However, again, I'm not speaking about that we can delay a acetabular fracture. No, the answer is no. We have to do it as early as possible. But if we are obliged to have some delay, yes, it's the best outcome are going to happen with the complex associated if it's applied within the first 5 days, and for simple fractures if it is applied till the first 15 days. But beyond 3 weeks, it was significantly worse in most of the fractures, because you are going to have organizing hematoma and some healing present at the fracture site. So again, ORIF should be performed as early as possible. what is the most important factor that can help you in the decision making, as I told you already during the whole lecture, is you, the surgeon experience, because we need you experience to do the assessment, to do the decision making, and also we need for you to have the best quality of reduction in achieving those difficult fractures. Actually, again, in JBJ, they have spoken about the importance of having dedicated units by specialist surgeons to do those difficult fracture reduction and assessment and achieving internal fixation for those difficult fractures as early as possible. Once you have done this, you are going to have the best outcomes. That's why in our university hospital we have this the new trauma hospital, and this is the picture of our trauma team. And also we have now the Asyut University Pelvis and Acetabular Fracture diploma. This is the first one in the whole Middle East. I urge you to join our team, and also I urge you to join all the meetings by the Egyptian Orthopedic Association if you are interested in doing your further studying of the acetabular fracture management, as well as joining the AO trauma with us. So the take-home messages of my presentation is that determinant factors for decision making, including intact roof, congruent hip joint, integrity of the articular surface, and stable joints. You have to properly understand the radiology and fracture classification. These are the most necessary prerequisites in order to understand the displacement and to decide which surgical approach. Dislocation of the hip requires urgent reduction, and you have to apply again the rule of traction. Most displaced fractures will require reduction. As I have told you that we have very minimal indications to do conservative treatment with acetabular fracture. Subluxation and hip stability are main indication, of course, for open reduction and internal fixation. And in order to do your surgery in the best way, you have to do the timing of surgery as soon as possible. I would like to thank all of you for listening to my presentation. Thank you very much.
Thank you so much, Professor Mahmoud, for this very interesting presentation. I think this can be considered, we can change the title as the guidelines for management of acetabular fractures. And we are seeking for the Egyptian guidelines for doing any sort of orthopedic interference. I think this can be a very good reference for the Egyptian guidelines for acetabular fractures. واللي انا احب اقوله يا دكتور محمود بيه ان انا I have a great honor ان كنت البيرسون اللي اعتمد الدبلومه بتاع الهيب اند بيلفيس بتاع جامعه اسيوط.
ربنا يبارك فيك يا باشا، والله العظيم.
الله يكرمك يا فندم. هي تم تحويلها ليا من لجنه القطاع الطبي على اساس ان انا يعني عميد كليه ليا خلفيه في العظام. انا I was fascinated with the curriculum of the diploma. انا قريتها بصراحه، ويعني انا مش هقول لحضرتك يعني انا عملت لها مش سبورت لان هي مش محتاجه سبورت، وانما انا كنت معجب جدا بكل حاجه في الدبلومه اللي شفتها. فقلت لهم يعني I strongly agree. اولا كفايه ان فيها اساتذتنا دكتور اسامه بيه فاروق وحضرتك وكل الاخوه الافاضل يعني، والكوريكولم بتاعها كان اكتر من رائع. ففعلا I recommend anyone who wants to have more knowledge about acetabular and pelvic fractures to join your diploma. It's fascinating.
شكرا.
Thank you so much. تاني حاجة إن أنا معجب جدا بإن حضرتك جبت سيرة بروفيسور بيتر جيانوديس. he's my best friend. وهو إن شاء الله I invited him في ال next upcoming Egyptian Orthopedic Conference من 24-27 نوفمبر. He will come and he will have a symposium and a lecture on pelvic fractures and a workshop. هو شخصية أكتر من رائعة، انسان لطيف جدا. فهو ان شاء الله هيكون موجود
للجمعيه وللتعليم
ان شاء الله هيكون موجود في المؤتمر القادم باذن الله تعالى.
ان شاء الله ان شاء الله.
Thank you so much, sir. We have some questions, I think, if your time allows, sir.
طبعا.
كان
اتفضل دكتور بهاء بيه، اتفضل يا استاذ. والله يا دكتور بهاء بيه يعني وجود حضرتك معانا من اول الميتنج ده شرف كبير يعني.
الله يخليك، ربنا يكرمك. دكتور بدران, from your experience, how can prevent the myositis ossificans? Especially, you know that the hip acetabular fracture is the most common causes for our presentation patient coming with complication like myositis ossificans. What is your management for these cases? Medical, surgical?
This is an excellent question. Actually, it depends mainly upon the first. It depends upon the technique of doing your the manipulation of soft tissue. Sometimes you may have a posterior fracture with affection of the roof and affection of the gluteus medius and minimus. Okay, so in order to decrease the incidence of myositis ossificans, you need to deal with those two muscles very carefully. And after doing your open reduction internal fixation, if you have any devitalized tissues, either from the trauma or from doing your surgery while manipulation of those fragments, all of them have to be excited. This is number one. Number two, still we know that, I know that this is a bit of concern that the indomethacin can decrease the incidence of myositis ossificans. That's why, from my experience, I didn't find any problems regarding the healing if I apply indomethacin for those kinds of fractures. But I don't know the experience of other surgeons. But from my perspective, الحمد لله أنا يعني ما شفتش مشاكل في الهيلينج في القصة دي. ولكن when you look to the literature, you are going to find that the indomethacin can have a role in minimizing the incidence of myositis ossificans. However, there are some concerns about the healing potential. So those are يعني أهم حاجة المانيبيوليشن للفراجمنتس والدبرايدمنت للتيشوز بعد ما خلص، وخصوصا مع العضلتين دول.
Thank you for your answers.
Thank you, sir. دكتور بهاء بيه موسوعة ما شاء الله في كل شيء يعني. First question from Dr. Gamal Qasim is there a classification including both pelvic fractures and concomitant injuries for the sacrum for treatment priorities?
Combined pelvis and acetabulum, you mean?
I think he's writing sacrum. I think there's no classification for that.
Classification for both pelvic fractures and concomitant injuries for SAC for treatment priorities. Okay. Yeah. Okay. Regarding classification, no, but you can classify according to the AO classification, which is 6-1 for the pelvis and 6-2 for the acetabulum. You can combine those classifications. But if your question is about the priority of doing the combined pelvis and acetabular fractures, actually, this is a very wide topic. It's not going to be answered in this event. You may have full courses for answering this. However, from my experience, if I have a combined pelvis and acetabulum, I usually begin with the undisplaced part, regardless of the fracture, if it is the pelvis or the acetabulum. Sometimes I have some concerns beginning with the acetabular fracture first, because I have to achieve anatomical reduction for this fracture, okay? And then I can go to the other injury of the pelvis. But this depends upon the kind of fracture you have. Sometimes you have transverse fracture acetabulum in place with a sacrum. So which one you are going to begin with? Okay, for me, I'm going to begin with the easy way, the easy fracture. But if you have both are difficult, I'm going to go with the acetabulum first.
The second question from Dr. Muhammad Said, do you think the stress test will displace non-displaced fracture and change from non-operative to operative?
Yes. The case we have applied, the second case we have applied, when you look to the X-ray, you're going to find that this is a small fragment. But when we apply the stress test, we have found that the distance between the femoral head and the cotyloid fossa has increased. And if this happens to you using the image, it's going to happen multiple, it is going to be magnified when this patient are going to put some weight on their femoral head. Sometimes we have found cases where the patients came with dislocation. And also some cases, you may have very small fragment of the posterior wall. And when you enter, you're going to find that the cause of this subluxation is from the part of the labrum has been displaced to be inside the acetabulum. So it's mandatory to do stress test under general anesthesia, even if you find that this fracture is less than 20%. But if it is larger than, or if it is displaced, or if it is less than 20% and involving the area of the roof here, okay, or high in the posterior wall, it goes without say, go for open reduction internal fixation.
Yes, sir. The next question, sir, from Dr. Ahmed Zaghloul. Could we assess the stability of posterior wall fracture through clinical examination without anesthesia?
This depends on on your muscle power, okay? Because you need to do stress test. No, my answer is no. My answer is no. You need to do any kind of anesthesia. Okay, even just give the patient an inhalation, but the patient needs to relax, because sometimes if the patient muscle power is okay, you may not find this kind of instability.
Yeah. Dr. Mahmoud, I'm sorry, we have many questions because of the importance of this topic. Okay, we can proceed.
Right.
The next question from Dr. Faisal El-Mosrati. What are the absolute indications for the open reduction for acetabular fractures?
The absolute indications. Anything away from the indications of conservative treatment. All of the fractures, you can consider it for open reduction term fixation, except for the list of 4 cases I have told you. Okay, posterior wall less than 20%, roof arc angle less than 45 degrees, ABC associated with column in elderly with secondary congruency, or in non-displaced fractures away from other fractures. Regardless of those, go for open reduction term fixation for all fractures.
Yes. Another question from Dr. Muhammad. What about trochanteric osteotomy to achieve anatomical reduction?
Excellent question. Okay, trochanteric osteotomy can be applied if you have a fracture that involving the area of the roof. Okay, so if your fracture is present, here and extending to this area, okay, you are not allowed to go through the muscle until to reach this area. So you can do trochanteric osteotomy in order to reach this area, especially if you are doing a posterior approach. Okay, so trochanteric osteotomy could be applied in cases of affection of the roof, or it can be combined with surgical hip dislocation if you have incarcerated fragment inside the hip, or if you have an impaction injury, or if you have an associated femoral head injury that you are going to do a trochanteric osteotomy as a step of doing the surgical hip dislocation. Okay.
Yes. Another question from Dr. Rami Ashur. What's your indication for primary total hip replacement in acetabular fracture?
Actually, I'm not doing an arthroplasty for acetabular fractures.
It's a big debate.
This is you can ask the speakers.
Yeah.
Sorry, مش هقدر اجاوب على السؤال ده.
It's a big debate. Another question from Dr. Muhammad Salah. How can we do dynamic stress view?
Dynamic stress view. Okay. Your patient is going to be, after doing the reduction, your patient is going to be supine like this, okay? And then you have done the reduction. The femoral hip is going to be flexed with slight internal rotation, slight adduction of the hip, and then you are going to compress against the knee, simply without trying to dislocate the hip. Okay? Simply, you just do a little push to the knee, because if you try to do some effort, you may dislocate the hip even in an intact acetabulum. Okay, so flexion of the hip 90 degrees, slight internal rotation, slight adduction, and then apply a gentle push to the hip, and put in your mind that the patient is under anesthesia, so he's going to be relaxed, so you may dislocate the hip, but gentle push.
Yes, sir. Another question from Dr. Muhammad. What's the rule of skeletal traction and when patient can weight bear?
Skeletal traction, no, I don't find any rule for it. Because we have spoken already about the timing.
Yes, you have mentioned it.
The timing has to be done as early as possible. So skin traction is okay for those patients, heavy skin traction. Skeletal traction, if I have a polytrauma patient, maybe, but for me, no, I don't recommend doing skeletal traction unless I have a very obese patient, for example, unless I have a combined fracture involving the femur and the acetabulum as well as the pelvis. Yes, I can apply skeletal traction, but the skeletal traction will jeopardize the importance of timing, and we have spoken already about the timing. That's why it's important to do it as early as possible.
Yes. Another question from Dr. Dr.
What is the least time you interfere, and after that you will not be referred to interfere, which affecting the outcome?
the papers which has spoken about this, it didn't speak about the minimum time. It has spoken about the maximum time. But even if the patient is ready, he's not critically ill, everything is ready, I can do the surgery of the acetate, and I have the team, and I have the unit that can deal with this, and have the expert anesthesiologist. I'm going to do the surgery as early as possible. It's not going to be emergency, of course. It's not going to be treated as an emergency way. But if the patient came now, I may prepare him in the morning. It's okay. The emergencies we have spoken about, they are very rare. Thankfully, alhamdulillah, they are very rare. However, sometimes I have to do it as early as possible. Like if I have, as I told you, Professor, in sciatic nerve palsy happened immediately after reduction. Okay, so I have to go now. If I have multiple trials of reduction and the reduction hasn't have been applied, because sometimes I may find incarceration fragment. Okay, I'm going to do it as early as possible. The minimum time, I cannot say.
What about neglected cases? If you have a patient with a neglected case, when you are prefer not to do?
Not to do.
Yeah.
Difficult question, Dr. Wahab.
Neglected 1 week.
There are certain criteria for this. We have to look for the patient age, the complexity of fracture, the quality of bone, the area, the affection of the roof, and presence of subchondral impaction. So if most of those are not present, I can deal with neglected fracture. However, if I have any, like for example, I have an elderly patient of a transverse fracture with some sort of arthritis, no, I'm not going to do any internal fixation, because again, the aim is to do anatomical reduction in order to have the best outcome. And if I have concern about the outcome is going to be worse, no, I'm going to go for arthroplasty later on.
Thank you.
Yes, another question from Professor Gamal Al-Ad. Did you find the sciatic nerve under the skin during open reduction and turn fixation of acetabular fracture during posterior approach?
Yes, it happened. But once it wasn't just below the skin, but it was there was rupture of everything, you know, the rupture of the posterior wall, rupture of all the tendons. So once I opened the skin and the gluteus, I found the sciatic nerve, but not under the skin, of course. But for my practice in Aswit University, we have to search for the sciatic nerve, even if the patient doesn't have any sciatic nerve injury, because you have 4 or 5 areas where you can injure the sciatic nerve during doing your Kocher-Langenbeck approach. For example, you can injure it when you are repairing the rotators. You can injure it when you are dealing with any fracture involving the posterior wall and extending to the area of the ischium, like in this area here. Okay, when you are doing any manipulation, you may injure it. Okay, so I have to look for it, even if the patient doesn't have any sciatic nerve injury.
Yes, sir. Another question from Dr. Yaqub. In labral injury during fixation posterior, you go for repair?
Yes. If I have one of my colleagues that can do ankle repair, is going to do it. But for me, I have done it, but not in هقولها بالعربي معلش يعني عملناها بأنكر بلدي كده. Yes, but you have to do it. If you find that the labrum is detached from the acetabulum, I have done it using a 4mm screw, and I have applied, I have refreshed the edge of the acetabulum, and then I have inserted it. Then I have applied the sutures attached to it, and then I have attached the labrum to its area. But if you have any experience with doing the ankles, or if you are ready with doing the ankles, please do the ankles. For me, I wasn't ready for this. That's why I have applied this technique. But it's important to do it.
Yes, sir. We have a question from 2 doctors, Dr. Muhammad Al-Said and Dr. Muhammad Al-Sharif. After 3 weeks, if the patient's presented after 3 weeks, what do you do?
I'm going to do it. But I have to, yes, but I have to, this is the same question as Professor Beha. Professor Baha was telling us if you have a neglected fracture, this is the same. Okay, if I have the other factors, bone quality, skin, the kind of fracture, the impact, other factors, if they are not present, I'm going to do this neglected fracture. However, I'm going to speak with the family of the patient, and I'm going to give them the. I'm going to speak honestly with them about the prognosis that we are going to do open reduction internal fixation, not to have the best outcome, but at least to have the next total hip in an easy way.
Yes, sir. The last question from one of our dear colleagues and attendees, the time of partial and full with bearing. You prefer?
Okay. It's important for me. Okay. In our hospital, we do it after 6 weeks. Okay.
Yes.
But sometimes if I have, like for example, an anterior column fracture, I can apply with bearing 2 weeks post-operative, especially if I'm doing it in a minimally invasive way. Okay. I'm looking to multiple factors. For complex fractures, I'm going to delay the weight bearing until 6 weeks. Okay, for the simple fractures that I have no concern about my fixation and the stability of the hip, I may allow the patient to have a partial weight bearing as tolerated, starting from week 2 or starting week 3 until week 6. But I'm not going to allow early immediate weight bearing, even if I have a non-displaced fracture, because sometimes it is displaced. This is important.
Yes, Professor Mahmoud, thank you so much for this very interesting lecture and very interesting presentations that's considered as a guidelines for management of acetabular fractures, Egyptian guidelines.
أنا متشكر جدا لحضرتك والله والدكتور بهاء وكل الحاضرين على الدعوة، وربنا يبارك في حضرتك دايما دكتور محمد.
Thank you so much. Thank you so much, sir. Our next speaker will be Professor Saad Sholah from Bana University, Egypt. Dr. Saad will speak about surgical approaches for fracture acetabulum. Dr. Saad?
Hello, Dr. Mohammed. How are you?
Fine, thank you. ازيك حبيبي؟
بسم الله.
Yes. Full screen, Dr. Saad. Yes, sir. Yes, sir. Thank you so much.
Thank you, Dr. Bismillah ar-Rahman ar-Rahim. At first, I want to thank Dr. Mohammed who gives me the chance to share in this wonderful event. Also, I want to welcome all the panel doctors and all my colleagues. Now we are going to talk about surgical approaches to the acetabulum. For the contents of this talk, we should talk about the surgical anatomy, how to choose the approach, anterior approaches, and most common used from the anterior approaches, extensile approaches, and posterior approach. At first, we should talk about the surgical anatomy. In surgical anatomy, we should know the bones, the muscles, the vessels that we may face during this approach, iliac vessels, femoral arteries, superior and inferior, gluteal arteries, coronal morts, and inguinal canal. Also, we should know most of the nerves that we will meet: the sciatic nerve, the femoral nerve, superior and inferior gluteal nerve, obturator nerve, and lateral femoral cutaneous nerve of the thigh. For choice of the approach, it depends on the location of the fracture, type of the fracture, and complexity of the fracture. And accordingly, we will choose whether to use the anterior approach, the posterior approach, or combined approaches. At first, we will talk about the anterior approaches, stop approach, ilioinguinal approach, and iliofemoral approach. For the modified Stoppa approach, this approach was first described for hernia repair by René Stoppa in 1975. Then it was revised by Hervin Salo in 1993 to use this approach for pelvic and acetabular surgery. Then it got the name of modified Stoppa by Collet in 1994. And here we can notice that there is great difference between Stoppa approach and modified Stoppa approach. The one that we use in our pelvic and acetabular surgery is the modified stopper approach. The indication for modified stopper approach, anything related to the anterior part of the acetabulum, like the anterior wall fracture, anterior column fracture, associate anterior column with posterior hemitransverse. If we have a T-shaped fracture, if we have transverse fracture with anterior displacement, and also any fracture involving the quadrilateral plate. The setup, as shown in the picture, the surgeon should be on the opposite side of the fracture. The C-arm should be on the same side of the fracture. The patient should lie supine on a radiolucent table with a Foley's caster, and we should put a plaster or a triangle under the knee to flex the knee. For the skin incision, we use the phalansteal incision. We place it just above the pubic, the symphysis pubis, and we can extend it laterally on both sides. For the superficial dissection, after making the skin incision, we divide the subcutaneous tissue in line with the skin incision in order to expose the fascia covering both recti. For splitting of the recti, at first we can find the plane, our plane, by pressing in the midline more proximally, just to find the plane where we will incise the fascia. For deep dissection, the rectal fascia, we incise it longitudinally along the linea alba, and the muscle belly should be retracted laterally. Following to that, we go beneath the symphysis pubis and open the space of radius. In the proximal part of the incision, care should be taken not to incise the peritone. Sometimes with multiparous patient or patient with history of intrapelvic adhesions, you cannot identify the recti because with recurrent pregnancy and labor, sometimes the gynecological doctor cut the recti and not do repair for it, so it retracted upward, and there is adhesions between the recti and the bladder, so you cannot identify the linea alba, and you cannot know how to separate. So you should go proximally, and sometimes when you try to separate it high up, you can open the peritone. The entire approach, and if you open the peritone, this is totally against the concept of the modified stopper, because the entire approach should be in the pre-peritoneal space. After taking both recti to the lateral, we should follow on the interior aspect of the superior pubic ramus to search for the corona mortis vessel. And the corona mortis vessel after that should be identified and ligated or clipped along the medial surface of the superior ramus, the vessel site. It's better to identify it before doing any incision of the fascia. Here, the corona mortis in Latin, it means the crown of death, because it's anastomosis between the external iliac vessels and the obturator vessels. Sometimes it comes from anastomosis between the inferior epigastric vessels and the obturator vessel. It may be arterial, it may be venous. So if you cut it, if you did not identify it well, and if you cut it, it will cause bleeding. And unfortunately, the venous one, and the veins, the connecting veins, is very fragile, more than the artery. The artery is more dangerous because it retracts. After that, the thick periosteum from the superior pubic ramus here till the iliopectineal eminence, we cut it sharply with the diathermy, allowing for deeper plantar dissection later on. The dissection is continued laterally upon the beginning of the iliopectineal eminence. And at this point, we should give great care for the femoral vessels and nerves. So after reaching the iliopectineal eminence, we can elevate the femoral vessels and nerves. The dissection after that continued subperiosteally, more laterally, following the upper border of the pelvic prim to expose the entire area of the superior pubic ramus. At this level, after incising the fascia, the obturator neurovascular bundle, which usually runs over the quadrilateral plate till the obturator foramen, we should manipulate the obturator nerve taking it downward and protect it with the obturate, with the pelvic floor with a spatula or a malleable retractor like that. With a cup elevator, the periosteum that covering the quadrilateral plate and the obturator internus should be elevated carefully. Where to put our humans? We can put our human. The first human, we put it here in the middle part of the superior pubic ramus, and the second part we put it here on the top posterior acetabulum, and the third retractor or human we can put it, but this is not human. Yani we can use a spatula. We can put it to protect the obturator nerve. Of course, with this human, you should take care because the external iliac vessels is here, and you just press against. So you should do it gently and the subperiosteally. At this point, we finished the modified stop approach. But adding the lateral window, it makes more evolution for the modified stopper, as we have a stopper approach, then they do the modified stopper approach, and then evolution done for the modified stopper approach to be the anterior intrapelvic approach by adding the lateral window. The incision for the lateral window, we can use adding the lateral window, yani opening in the iliac bone, if we have like any fracture, including the posterior part of the ilium, including the sacroiliac joint, and we need to make more exposure posteriorly. We divide. At first, we do the skin incision here on the lateral aspect of the iliac crest. After that, we divide the subcutaneous tissue and expose the fascia overlying the external oblique muscles. Here, it's very important because some people or some surgeons like do the separation over the iliac crest, and at this point, there will be like horrible bleeding. So it's better to do your incision between the external oblique muscles and between the glutei. You will find like a white line, what we call white line with no bleeding. Okay, we open it, we make like our incision here, and after that, we should elevate the external oblique muscle subperiosteally from this line, extending from this line, going upward from the iliac crest, and after that, using the same periosteal plane to start elevation of the iliacus muscle. When elevating the iliacus muscle, this is the iliacus muscle. When we're elevating the iliacus muscle, you sometimes find some bleeding from the nutrient vessel. You should deal with the bleeding, and you should use bone wax. We continue with careful blunt dissection to the interior part of the sacroiliac joint. Here, after elevating of the iliacus muscle, we go like meticulously till we reach the sacroiliac joint medially. At this area, we expose the pelvic ring. We proceed anteromedially till the level of the iliopectineal eminence, and so we expose all this area to help us if we have like extension into the iliac bone, or if we have like anything any injury in the sacroiliac joint. Elevation of the iliacus muscle, you can elevate it till you reach the sacroiliac joint and till you see the sacroiliac joint capsule. And you can put like another human, you can put it, but on the upper part of the sacroiliac joint. Of course, for the closure, we start closing the anterior incision or the phenastile incision, the midline incision. We start doing this incision first. Sometimes we need to put a drain, especially in the space of rhesus. And after that, we should make repair for the recti. And also for the lateral window, we close it in layers. Sometimes we need to put a drain, but most of the time we did not use drain here in the lateral window. The dangers, the obturator nerve. Yes, we can make obturator nerve injury during exposure of the quadrilateral plate, external and external iliac arteries. Yes, this is during the corona mortis, and also by using the human on the posterior top of the acetabulum. superior gluteal vessels, yeah, we can injury this as it comes out of the greater sciatic notch. The corona mortis or the crown of this, we can injure it if we did not identify it. And by the way, in most of literature, the corona mortis is present in 85% of cadavers, so it's not uncommon to find it. Of course, you are in danger to make like injury in the urinary bladder. The second common approach is the ilioinguinal approach. It was developed by Luternel in 1960. It allows exposure of the entire iliac fossa and the pelvic brim and the quadrilateral surface, anterior column, all the anterior column, superior and the inferior pubic rami. The indication, usually it's the same indication like the Stupa approach. For positioning of the patient, we put the patient in supine position using caster and the affected leg slightly flexed. The incision start 3 to 4 centimeters over the symphysis pubis. We proceed laterally to the anterior superior iliac spine, then along the 2/3 of the iliac crest, and we can extend beyond the convex portion of the ilium. After opening the skin, we go to the superficial dissection. We dissect through the subcutaneous fat in line with the skin incision. This is the external oblique aponeurosis exposed muscle. We found the lateral cutaneous nerve of the thigh at the superior part of the dissection, and also we should give great care for the external spermatic cord for the cord. External oblique. After that, the aponeurosis should be divided from the superficial inguinal ring, making unroofing for the inguinal canal. Take care to the ilioinguinal nerve, and also take care to the spermatic cord and the round ligament. In deep dissection, the rectus abdominis muscle is divided 1 centimeter proximal to the insertion into the symphysis pubis, using a blunt dissection to make a plane between the back of the symphysis pubis and the bladder. This is the space of Ritz's. And after that, continue cutting the whole musculature. After cutting the musculature, which is here is the transversus abdominis muscle and internal oblique muscle. After cutting off the rest of the musculature, you find the fat covering the peritone. At first, you ligate the inferior epigastric vessel, complete division of the musculature structure for the posterior wall of the inguinal ligament, and after that, you can find this fat covering the peritone. We use a swab to push the peritone upward to reveal the femoral vessel and the nerve and the iliopsoas muscle, which will be the landmark later on to show us the 3 windows. We isolate the femoral. For the femoral vessels, we isolate the femoral vessel along with the sheath and protect them with a sling. We strip the iliac muscle from the inner aspect of the ilium. We continue stripping of the iliac muscle from the inner wall of the ilium to reveal the sacroiliac joint. The same as lateral window in Stupa. We incise the iliopectineal fascia. Here, the iliopectineal fascia. We incise the iliopectineal fascia upon the bone. We retract the iliopsoas and the femoral sheath either medially or laterally to reveal the medial surface of the acetabulum or the superior pubic ramus and the inner surface of the ilium around the sacroiliac joint. We have 3 lateral window, lateral to the iliopsoas, and they give access to the inner aspect of the ilium. Middle window, it's medial to the iliopsoas, but lateral for the femoral artery and the vein, and they give access for the quadrilateral plate. And the medial window, it's medial to the femoral vessel and the vein, and it gave access to the superior pubic ramus and symphysis pubis. This is the medial window between the femoral vessels, medial to the femoral vessels, and this is the middle window, give access to the quadrilateral plate between the iliopsoas and between the femoral vessels, and this is the lateral window, it's lateral to the iliopsoas and give access to the ilium. For closure, we bought a drain, we place it in the space of Ritz's. Also, we make a repair for the tendon. talus fascia and conjoint tendon for the internal oblique and the transversus abdominis are attached to the inguinal ligament, the external oblique aponeurosis is repaired. Regarding the extensile approaches, we should know that there is an approach which is called the iliofemoral approach developed by Lioternel. The indication, we did not use it. Actually, I don't use this approach, but we should know like a hint about the indications. Transtectal transverse fracture with roof impaction, transverse with posterior wall fracture, and T fracture, especially with posterior wall involvement, both column fracture with posterior wall or posterior column. And this is the most important one, especially in delayed fixation of both column or T type or transverse plus posterior wall. So we confine this one for the delayed fixation, but of course, as I said before, that it's not commonly used. Also, if you wanted to make any correction for malunion, non-union, I will show you some pictures about the iliofemoral approach. It's a devastating approach, horrible approach. You are working on the outer surface of the iliac bone, stripping everything and expose everything. So it's better, it's fit the correction of the deformities and also for the delayed or malunited fracture. About the posterior approach for the acetabulum, we will talk about the Kocher-Langenbeck approach. Kocher-Langenbeck approach, it gives access to the posterior wall and the posterior column. As Dr. Mahmoud said, if we do trochanteric osteotomy plus surgical dislocation, we can do trochanteric osteotomy. If we plan to do surgical dislocation, yes, we can combine trochanteric osteotomy with the Kocher-Langenbeck to give us more exposure, especially if we have lock like for the anterior wall. Indication: posterior wall fracture, posterior column fracture, posterior column, posterior wall with transverse fracture, and some T-type fractures. The position of the patient lie in prone position or in lateral position with knee flexed to decrease the tension on the sciatic nerve. For the landmark, this is the BSIS. This is the greater trochanter. This is the shaft of the femur. So we start our skin incision a few centimeters distal, few centimeters lateral to the BSIS, continue over the greater trochanter, continue over the tip of the greater trochanter, and go down to of the femur on the lateral aspect. Okay, we can go down up to like 10 centimeter to even to 15 centimeter according to the fracture. This length, the whole length is not mandatory. We use it according to the type of the fracture. After that, fascia lata is incised in line with the skin incision. The incision extends superiorly along the anterior border of the gluteus maximus for not to exceed 7 centimeter. Otherwise, you will find a leash of vessels. It includes the inferior gluteal nerve and the vessels. We split the gluteus maximus in line with its fibers, and in the distal part of the incision, we incise the iliotibial tract with its fibers up to the mid-third of the thigh. This is the picture after exposure, after making a splitting of the fibers of the gluteus maximus, and after doing extension into the femur, we make retraction for the wound. We can identify the piriformis fossa, the tendon of the internal of the obturator internus, and the both gemelli, and this is the quadratus femoris. We find here a layer of fat. We remove the layer of fat, and the short rotators are visualized. The sciatic nerve. At this point, the sciatic nerve is visualized. The sciatic nerve usually passes from the greater sciatic notch under cover of the piriformis and pass over the tendon of obturator internus and both gemella. So it's simply, if you wanted to search for it, you can you can find the greater trochanter and the ischium, and you find it in the midway between both. The piriformis tendon is isolated, and the suture is placed 1 centimeter from its insertion, and then the tendon is dissected. We reflect the piriformis belly laterally to expose the retroacetabular surface of the greater sciatic notch, this one. After that, the tendon for the obturator internus and both gemelli, the conjoined tendon, we isolated and we cut it 1 centimeter from its femoral insertion. You should give great care not to cut the quadratus femoris, because you will find here a vessel. It's the medial circumflex femoral artery. And this is the main cause of AVN, especially fixation of the posterior wall or column. If you cut or during isolation of the obturator internus and both gemelli, if you cut and this vessel, you should understand, or you should consider that you will have AVN later on. This is if we follow the tendon of piriformis, we are in the greater sciatic notch. If we follow the obturator internus and both gemelli, we are in the lesser sciatic notch. We can insert like a retractor in the lesser sciatic notch and the one anterosuperior in the direction of the anterior inferior spine here to expose the posterior column, one here and one here. Sometimes we put like a Hohmann here in the greater sciatic notch to give us more access for the posterior column. But you should know that the most common cause of sciatic palsy, post-operative, and especially when using the Kocher-Langenbeck approach, is because of the shoulders of the retractor. After that, this is the capsule. If you wanted to open the capsule, we open the capsule in T shape. I want to see something like related to the cutting of the or carrying of the medial circumflex vessels. This is the difference between the posterior approach for the hip. In acetabulum, we should give great care for the medial circumflex vessel, but in the hip, if you are going to make like total hip through the posterior approach, it's okay if you cut it, because you don't have any fears about the AVN later on. As Dr. Baha asked about said about the major cause of the cause of I'm sorry. Yeah, here. The most common cause of myositis ossificans is the injury in the obturator internus and the gluteus medius and the gluteus minimus. Sometimes we find that there is great injury for the tendons related, especially the gluteus minimus. So the debridement is one of the common causes to decrease the incidence of this thing, of myositis ossificans. As Dr. Badran said, some people use endomethacin. And recently, in some literature, they said that they use low dose of radiation for the myositis ossificans. We do meticulous debridement before closure. All the tendons are reinserted, and the split parts of the gluteus maximus are approximated. For the gluteus maximus, we don't make repair for the muscle. We just make approximation for the ends. After that, we do closure for the iliotibial tract and the subcutaneous and the skin. Great care should be given for the sciatic nerve injury, for infection, for pterotropic ossification, for the superior gluteal artery injury, for the medial circumflex femoral artery injury. This is the modified Gibson approach. It's all the same like Kocher-Langenbeck approach, but the only difference is that he tried to make an interval between the gluteus maximus and the gluteus minimus and the gluteus medius, but all other things are the same. Thank you. Here I bought some slides related to the difference between modified stop and anterior intrapelvic approach. Here is the difference between modified stop and anterior intrapelvic approach. As I told you, the original stop approach did not have a lateral window. So the modified stop approach did not have also lateral window. After adding the lateral window, we called it anterior intrapelvic approach. It gives us excess access, especially if there is associated posterior fracture related to the ilium or to the sacroiliac. Here the incision is the same in both, but in the anterior intrapelvic approach, we use the fenested incision with the lateral extension. The axis here, retropubic space. Here we reach the retropubic and also the iliac wing. For visualization, there is limitation of the iliac exposure, but here it gives us better exposure for the ilium. Posterior column axis, here we cannot. It's here improved. Also, it's not fully, but at least it's improved. For the coronal morts, required to handle both in both like techniques. This is best for anterior column and the quadrilateral blade. This is especially if there is any extension for the posterior column. Thanks a lot.
Thank you so much, Professor Saad Shulah, for this very interesting presentation about all the approaches for fracture acetabulum. We have a question from Dr. Muhammad. It's a very important question. What I have to do if I cut the coronal morts to stop the bleeding?
Ligation for the external iliac. Yeah, unfortunately, it happened once with us. It's devastating. We should call the vascular doctor. Of course, he do nothing. He just make ligation for both, and after that, the patient face post-philippitic edema.
Yeah.
The patient will die. This is number one. The patient will not die, okay? But the patient will suffer more because he will have post-operative bilateral lower limb edema, and there is no other options.
Yeah, unfortunately. Thank you so much, Dr. Saad, for this very interesting presentation. هو طبعا presentation مجمع لكل الابروتشز surgical approaches للفراكتشر acetabulum. It's a very interesting approach, Professor Saad. Thank you so much. Thank you so much, Saad.
Thank you for it.
دلوقتي مسك الختام وختامه مسك، يعني مع التوك بتاع استاذنا الكبير بروفيسور بهاء كرنة. Professor Baha will speak about protrusion as supply. Very interesting topic. وزي ما عودنا الدكتور بهاء بيه محاضراته كلها محاضرات شيقة وممتعة في أي حاجة. دكتور بهاء موسوعة ما شاء الله، في السباين، في البلفس، في الارثروبلاستي، في كل حاجة يعني.
الله يخليك، ربنا يكرمك إن شاء الله. You can see the presentation now?
Not yet, sir. It's starting to be shared. Starting to be shared. Yes, yes, sir. Yes, sir.
Okay, now my talk about protrusion acetabuli, which is mean other word acetabular protrusion. طبعا بشكر طبعا اخونا العزيز سياده العميد الدكتور محمد الاشهب على الدعوه الكريمه وافكاره النيره. دايما هو بيعمل لنا حاجات كده كل شويه بنشوفها ان شاء الله. ما شاء الله، ربنا يكرمك ويجعله في ميزان حسناتك في الكونتينوس ميديكال اديوكيشن يعني.
جزاكم الله عنا كل الخير يا استاذنا.
ربنا يكرمك. We will start about some history. In 1824 German pathology اللي هو أدو ويليام أوتو documented the first case اللي هي the right acetabulum protrude in the pelvis like a half an orange. هو أول واحد اتكلم على البروتروزو وسماها، حتى بيسموها دلوقتي الأوتو pelvis. Also known as arthrochitoidiasis or subsidence of the joint, and hence it's also known as Oates pelvis. What it means, the definition, it is an intrapelvic displacement of the acetabulum and the femoral head. Also can be represented by an intrapelvic protrusion of the acetabulum. It should be differentiated from coxa profunda, and we will speak about it on radiology. And this is an example of the cases of Oates pelvis. So the causes of this disease is primary, like it can be unknown causes, and this is an idiopathic, and secondly associated with osteoarthritis, rheumatoid arthritis, and many diseases. So the primary one, which is a primary acetabulum protrusion, is characterized by progressive protrusion in the middle-aged woman. The condition may be associated with osteoarthritis and may be familiar. The second one, which is due to the pathology or traumatic, like Paget disease, psoriatic arthropathy, rheumatoid arthritis, ankylosing spondylitis, osteomalacia. It is due to metabolic bone disease, bone softening disease, osteogenesis imperfecta, Marfan syndrome, and traumatic or like in hemophilia in advanced case. This type of the disease can be unilateral or bilateral. Unilateral like conditions like TB arthritis or like traumatic or fibrous dysplasia, and can be presented as bilateral condition like rheumatoid arthritis, Paget disease, and osteomalacia. So the primary protrusion, اللي هو autopelvis, this is the primary is characterized by progressive protrusion and always in aged women. It can be bilateral in 1/3 of the patient and always related to the osteomalacia. The primary form of pelvis are involving the hip and occur mostly often in the female and causing pain and limitation of the motion at a relative early age. A common deformity can be presented also. There is a varus deformity of the femoral neck and arthritic conditions. The etiology always it remains a diagnostic by exclusion. This is the primary type. As such, many of cases reported in the past and may have a secondary to of under the undiagnosed condition. There are following three headings. Either it is an inflammatory or destructive condition of the hip joint leading to protrusion, or the qualitative deficiency of the acetabulum bone, like bone softening disease, or developmental abnormality or gross disturbance of the triradiatic cartilage. The second protrusion is the secondary form and may be caused by femoral head prosthesis, cup arthroplasty, septic arthritis, central dislocation, or total hip, or may be presenting bilaterally like in Paget disease, Marfan syndrome, rheumatic arthritis, ankylosing spondylitis, and osteomalacia. The deformity may be progressive until the femoral neck impingement on the side of the pelvis. Medial migration of the femoral, and you be cautious about the sciatic nerve, which can be nearby the joint. So the secondary protrusion can classified into infection, inflammatory condition, metabolic, genetic, or neoplastic and trauma. Infection like gonococcus, tuberculosis, syphilis, staphylococcus, and streptococci. Inflammatory condition like rheumatoid arthritis, spondyloarthropathy, idiopathic chondrolysis. Metabolic like in Paget disease, osteomalacia, hyperparathyroidism. And in genetic like osteogenesis imperfecta, Marfan syndrome, Ehlers-Danlos syndrome, neurofibromatosis, sickle cell disease, and other. Neoplastic like in a primary neoplasm, like in case of hemangioma, or metastatic disease, or after radiation, which is inducing an osteonecrosis. Also, don't forget about trauma, which is the acetabulum fractures. What about the symptom of this patient? The patient is coming by hip pain and stiffness with the limitation of the range of motion, progressive difficulty in walking, and possible groin pain. Patient cannot squat like this. Also, there will be hyperlordosis of the lumbar spine, which compensated for the fixed flexion deformity of the hip. This is due to protrusion of acetabulum, will lead to flexion of or increase in inclination of the hip, and also there is increase for lumbar lordosis. What about clinical feature? Marked always with the female, more common in the middle-aged person. The condition is characterized by bilaterality. Typically, the patient with primary protrusion acetabulum presented with increase for hip pain with stiffness rather than increase for stiffness rather than the pain. Deepening of the acetabulum leading to painful limitation of abduction due to impingement of the greater trochanter with the outer aspect of the acetabulum. Further progression leading to adductor spasm and fixed flexion deformity will develop. In untreated patients, the patient ultimately develop ankylosing of the hip. What is the symptom? The symptom is common in the hip pain with the groin or thigh pain, stiffness, and reduces the range of motion, cannot squat, and limping or difficult for walking. In advanced case, the leg lengthening discrepancy, and the visible deformity in severe case. The diagnosis modality, you can do an X-ray, you can do a CT, and you can do an MRI. And the X-ray shows a acetabulum extending medially to the cochlear line, and we'll speak about this in detail. CT scan providing detail of the bone structure, MRI evaluating the soft tissue involvement. Before we go for the X-ray, you have to know about the normal X-ray and do a better true AP. The true AP and the true lateral view, the hip placed in 15 degrees of internal rotation. From this, you can know the radiological line, which is very important, the acetabulum roof, the ilioischial line, cochlear line, the iliopectineal line, and the Shelton line. This is very important line. By these lines, we will know about the protrusion. So the radiological feature in the interpelvic displacement of the medial wall of the acetabulum. The diagnostic criteria in the AP radiology of the pelvis, there is a projection of the femoral head medial to the ilioischial line, and we'll see it in demonstration now. The acetabulum fossa is greater than 3 millimeters beyond the ilioischial line in men and greater than 6 millimeters in women. The center edge of angle greater than 40 degrees, and the medialization of the medial wall of the acetabulum passing the ilioischial line in the cochlear line. And the useful trick is the acetabulum cavity will often, but not always, seen in protruding medially to the iliopectineal line. So we'll go in more detail. Radiological, about the medial displacements of the acetabulum, breaking the Shelton line, and this is in a cochlear line and center edge of angle. So this is an X-ray demonstrated the Shelton line, which is coming like smooth like a C line, and this is the protrusive acetabulum. There is disturbance of the Shelton line. This is the first sign in radiology. Then the protrusive acetabulum, it can occur when the femoral head. Know that we are speaking about the femoral head overlaps the ilioischial line medially. This is the femoral head here passing the ilioischial line. So this is the protrusive acetabulum. This is the normal X-ray, and you can see by that's the teardrop and the ilioischial line. What about this demonstration? The head of the femur passing the ilioischial line. Coxa profunda, the difference between protrusion and coxa profunda, the fossa of the acetabulum. The fossa of the acetabulum overlapping the ilioischial line medially. This is the fossa of the acetabulum passing the ilioischial line, not the head of the femur. This is the difference between coxa profunda and acetabulum, protrusive acetabulum. And here you can see that the coxa profunda, the acetabulum as fossa passing the ilioischial line. And this is demonstrating the coxa profunda. There is what we call displaying the Renward method for center of rotation. Center of rotation of the femur is a very important landmark and giving you a good idea. But how we can do it? We can do it by two horizontal lines at the level of the iliac crest and the ischium. Then make it the 3 point. Now we will do 2 lines, and we'll see it in the demonstration next slide. We have 3 point, the point A, which is 5 millimeter lateral to the intersection of the Shelton line and the cochlear line. Point B is located superior to the point 1 by a distance of 1/5 of the height of the pelvis. Point C, a similar distance horizontal from the vertical line. هيبقى عندنا بعد كده مثلث متساوي الاضلاع isosceles triangular was completely by connecting the point A, B, C. The midpoint of the line AC is an anatomical اللي هي central of rotation. هنشوفها بقى على الديمونستريشن على الاكس راي. So the pelvic height, this is the first line, but the iliac crest, ischium, This is the height of the pelvis. We'll take 1/5 of this height of the pelvis. Then we'll make one line, which is 5 millimeter between the Shelton line and coronal line, 5 millimeter. Making a vertical line, which is 1/5 of the height from this point to this point, 1/5 vertical line. Then we'll take a horizontal line, which the same size, the fifth to the lateral edge of the acetabulum. Then this is the point C. Then another line which is connecting the C and the A line. And the midpoint here, this is the COR. This is the center of rotation. What about Weber angle? The center edge angle, the CE angle, must be less than 40. This can be done by a vertical line drawn through the center of the femoral head, اللي احنا عملناها قبل كده, and the line connecting the center of the femoral head to the lateral edge of the acetabulum. Normally between 25 to 39 degrees. Increase with the deeper acetabulum, بتزيد الزاوية دي مع الديب acetabulum اللي هي كوكسر اللي احنا اتكلمنا عليها old pelvis and more over coverage. ده الاكزامبل اللي هي center edge of angle اللي هي بناخد اللي هي one vertical line, another line touching the lateral edge of the acetabulum. The angle between these, it would be less than 40 degrees. This is central edge angle. If it is increasing, like here, if this line become like this means that the acetabulum is protruding inside. This is the angle leading to a diagnosis of old pelvis. What about the teardrop sign? The teardrop, there is a perfect distance, or there is a distance between the head and the teardrop. If this distance disturbed, this is acetabulum abnormality protruding into the pelvic cavity, which can alter the appearance of the teardrop. Teardrop, it can be sometimes, say, as a U figure or coronal teardrop. There is classification which has been proposed by Gers and Charlie. They measure the distance between the upper margin of the superior pubic and the outer of the acetabulum protruding into the pelvis. Was estimated, give 3 degrees of protrusion. So this protrusion is grade 1, is what's called the mild protrusion, which measure 1 to 15 millimeter. Grade 2 is moderate protrusion with 6 to 15 millimeter. And the grade 3 is severe protrusion, which is more than 15 degrees. There is, this is an example from the superior pubic rami to the protrusion of the acetabulum. And this is the grade, which is grade 1, grade 2, and grade 3. There is another way to measurement, it's called coronal line method. Measurement is a distance from the coronal line up to the acetabulum medial edge wall. From the coronal line, not from the pubic rami, to the protrusion, which can be classified into grade 1 middle protrusion measurement from 1 to 5 millimeter, and this grade 2 and grade 3, which is more than 15 millimeter. In 2024, there is another simple classification and surgical recommendation with being proposed by Ann, and he measured the line and classified it into class 1, which is medialization of the femoral head does not violating the ilioischial line. Class 2, which is the femoral head is between the ilioischial and the iliopectineal line. And the last one with the class 3 is the femoral head is medial to the iliopectineal line. And this is the last classification has been proposed 2024. What about the treatment options for these patients? We have a conservative management in the middle or asymptomatic case, like doing a physiotherapy, strengthening and the pre-articular muscle to support the hip function. Pain management, utilizing the analgesia or anti-inflammatory medication. Also, don't forget if you have a medical condition, you can treat it like osteomalacia. Active modification, adopting activity to reduce the stress on the hip joint. What about the surgical option? We have two types. If this patient coming as a pediatric, we can do a surgical closure of tri-radiated cartilage, which is responsible for development of the acetabulum. Also in adult, we have many choices like arthrodesis, excision arthroplasty, total hip arthroplasty, acetabulouplasty, and the vulvar intertrochanteric osteotomy. So what about the intertrochanteric osteotomy? It is the aim of this is to reduce the pressure on the floor of the acetabulum, reduce the impingement of the superior acetabulum margin, and this indicated in young patient with minimum arthritic change in the hip joint. This paper was published. It says the intertrochanteric valgization osteotomy for the treatment of the primary protrusion of the acetabulum. And he was treating 6 patients with 8 hip, follow up for 5 years, has a good in 7 cases, but 1 patient who was 49 years old at the time of separation had moderate arthritic changes visible radiography. He not recommended for this for all the patient who has arthritic changes. McBurn et al. He published paper in 2001. He was treating 12 patients with 19 hip, age between 21 to 33, follow up for 7 years, and good to excellent result for 12 patients, and poor result were noted in 5 hips in the 4 patients age 42. He concluded that this procedure should not be performed on the patient over 40 years of age or whom significant degenerative changes were evidenced on the plain radiography. McBurn, he concluded also, he recommended in the skeletal immature patient, try radiating fusion, occasionally combined with intertrochanteric fracture, he recommended. For the young patient, valgus intertrochanteric proximal femoral osteotomy is recommended. For the patient who more than advanced arthritis, total hip arthroplasty with lateralization of the cup to the normal position, providing a predictable long-term solution. What about the total hip? This is another option for this patient, especially in old age, indicated in the old patient or in the patient with significant degenerative changes. An aim to lateralization of the cup. And this can be done by either impacting bone grafting, muscularized or fragment bone grafting, or prosthetic reinforcement rings. This is a demonstration of how to do an periarticular and acetabulum cup and bone grafting. And this is how motorizing bone or fragmentation bone grafting. You can using the head and making a 5 millimeter and then impacted, and then impaction bone grafting to cover, especially in the mild cases. This is a demo demonstration. This is another way you can use an internal layer of the periosteum and shape of the bone graft, then bone cement, and then acetabulum component. And also you can use a mesh to cover, just protruding, then bone grafting, then layer of bone cement, then polyethylene acetabulum component. And this is another way, meshing in situ and fixed using screws with containing defect in the normal. If the defect is now filled with the bone graft, the graft are impacted with the hammer and then bone cement to the cup. I recommended these cases, but I use a bone grafting, and you can use the reamer, the acetabulum reamer, in a reverse way, and this will give you a good smooth surface. Then you can use, after that, you can insert the acetabulum component. This is a total hip arthroplasty in the protruded acetabulum, which is presented in 20 zones. The defect can be effectively treated with lateralized cementless porous-coated component. Motorized autograft is useful to fill the middle defect. However, if the rim is unequal to providing mechanical support, cementless cup due to bone loss or osteoporosis, cementless cup reconstruction can be resulting in medial migration. If the rim support is inadequate, reconstruction cages is more appropriate option to gain fixation to the pelvic above and below the acetabulum. This is 2024, and he used biological total hip arthroplasty combined with impaction bone grafting. He treated 20 patients with 24 hip, and they are ranged from type 2 to type 3 protrusion. He used autogenous femoral head granule bone and allograft. Biological porous acetabulum cup was fixed by breast fit, followed up to 10 years. All the patient could move independently without assistance, and he has a good result. This is a systemic review of the total hip arthroplasty in pertussis acetabulum, and this been mentioned in 2024 in March. They found that there is 18 articles were included, 8 were prospective study and 10 were retrospective, and they presenting 783 hips. The mean age about 6 years, 80% of the female, follow up to 15 years. Good outcome have been achieved with total hip using uncemented cup with bone graft. Concluded that the concept of restoration of the anatomical hip center of the rotation is paramount for good outcome and better survival of the implant. It is important when using uncemented cup with bone graft. So we come to the key point: restoring the anatomical hip center to optimize the biomechanic, address the bone loss with graft and reinforcement as needed, ensure stable fixation of the acetabulum component. Now we'll go for some cases which is presented, and you can be a challenge for the surgeon. This is the patient who has come to you with acetabulum protrusion due to erosion of the acetabulum component and migrating to the pelvis. And this is an X-ray. And this is 3D dimension. You see that this migration of the acetabulum protrusion in the pelvis. And this is CT. And this is a patient who was treated by impaction bone grafting and reinforcement ring, and with total hip and the long stem with locked stem in the femur to overcome the defect in the femur also. And this is the close-up views. You can see that the impaction bone grafting was completely and starting to have healing. And this is the reinforcement ring. This another case was due to infection, and the protrusive acetabulum due to infection, and there is was treated by spacer, and this patient suffering from prosthetic fractures. And this is 3D. And the patient was treated after removal with reinforcement ring, impaction bone grafting, reinforcement ring, and total hip with long stem. And this is bone grafting. You can see it in complete, which has filled the cavities. This was a female patient, 70 years old, had bilateral femur arthroplasty 20 years ago. She is complaining of painful hip, loss of abduction, and difficult to walk, bilateral hemoarthroplasty. And this patient came by this position, which is, you know about this. This is, you have, before we use monoblock, which we have Thompson and Austin Moore prosthesis before we have the bipolar. And this was treated by this monoblock prosthesis. And this is the lateral view. You can see the erosion of the acetabulum. And you can see that there is an migration and protrusion. And the patient was treated by impaction bone grafting and the reinforcement ring and the primary total hip. This is post-operative for the same patient. And this is a follow-up. Prognosis for this patient with out pelvis: with early detection and treatment, the patient can manage symptomatic effectively. Severe cases may require surgical intervention for improving the quality of life. In conclusion, early diagnosis and appropriate treatment are crucial for the management of symptomatic and maintain the function. So in conclusion, protrusor acetabulum is rare but imperfectly full condition. Protrusor acetabulum is progressively hip disorder that can significantly affect the mobility. Early diagnosis and appropriate treatment are the key to improving the outcome. Take away message. Awareness of the symptom and the risk factor can lead to timely intervention. At the end, thank you for inviting me, and I am happy to have any questions to ask.
Thank you so much, my dear Professor Karana, for this very interesting talk about a very interesting topic, which is protrusio acetabular, and how can we differentiate between it and coxa profunda, of course. You have mentioned it, sir. We have a question from Dr. Gamal Qasim. For 75 years female with advanced rheumatoid arthritis and bilateral protrusio acetabular can be a role for operative interference?
Yes, this patient is a candidate for total hip, but we have to measure the acetabulum, and we know which grade. If it is primary grade, we can make an induction bone grafting and total hip. If it is more, we need more induction bone grafting, and we can support. But always looking for the quality of the bone. Is it osteoporotic, non-osteoporotic? And I think this patient with rheumatoid arthritis is always osteoporotic. So induction bone grafting, and you can use cementless cup with enhanced biological fixation.
Yes, sir. Thank you so much, sir. I think we have no more questions. بمحاضرة أستاذنا الدكتور بهاء بيه احنا بنصل we reach to the end of this very fruitful scientific day, the Pelvic Specialty Day. I would like to thank all our dear speakers from India, from Canada, from all Egyptian universities. Many thanks for all of you. I think it's a huge scientific mega event. It will be uploaded on the Egyptian Orthopedic Association very soon, inshallah. شكرا جزيلا أساتذتنا الأفاضل. ودكتور محمود بيه انا اسف في يعني بعض الزملاء بيسالوا على دبلومه البلفس في اسيوط، فلو سعادتك مشكورا تسمح لنا ان هم يتواصلوا مع حضرتك نبقى شاكرين يعني.
تمام يا فندم، مفيش اي مشاكل ان شاء الله.
ربنا يكرم حضرتك يا فندم. Thank you so much for all of you. وان شاء الله نشوفكم حضراتكم الشهر الجاي ان شاء الله في another specialty day. وكل عام وحضراتكم بالف خير. شكرا جزيلا اساتذتنا الافاضل. تصبحوا على الف خير يا فندم.
شكرا. السلام عليكم.
شكرا. شكرا اساتذتنا.